7. Anything I need to go over? Everybody good? Let me get your scores. Dina, Ashley. Okay, so you missed one?
Yep.
All right, Abby. Thank you. Caitlin. Carsey. Thank you. Pilar. Thank you, Michelle. Thank you. Lisa. Thank you. Okay. All right. Oops. Let's go here. All right, this should be our very last review of everything that we've learned up until this point. Monday will be our last 3 skills. So we're almost there, guys. You've done a great job. So how do we know what to do with each patient? Care plan. It's not just about the care plan. It's about the whole care plan. And what does that mean? Right. What happens if you can't follow the care plan for any reason? Notify the nurse. So if the patient refuses, okay, if you don't have the right supplies, if you are unsure how to do the skill, okay, so our job is very, very easy. We follow the care plan the way we've been taught to do, or we notify the nurse. There is no third option. Please keep that in mind for the written test. There is no third option. We either follow the care plan or we notify the nurse. Now, the only exception to that, and there is an exception, the only exception to that is emergencies. Because with an emergency, we have to act now. We can't wait for the nurse. So emergencies would be things like choking, fires, burns, chest pain, signs of a stroke, difficulty breathing. So let's talk about that really quickly. Fire. If there's a fire, we remove the patient first, always. Then activate your alarm system, contain the fire by closing the door, and then extinguish if possible. If the patient has chest pain, do not delay. Get them in a comfortable position, usually sitting upright. Don't leave them alone. Send somebody to go get the nurse. If the patient is having a seizure, we have to ensure their safety. We don't ever put anything in their mouth. We never restrain them, but you want to move any furniture out of the way that they might bang into, or put a sweatshirt under their head so their head isn't hitting the floor. And you want to time the seizure. Again, don't leave the patient. Yell for somebody to go get the nurse. If the patient is having signs of a stroke, so signs of a stroke would be facial drooping on one side, sudden difficulty speaking, lack of coordination, speaking gibberish when that's unusual. Those are all signs of a stroke. Again, don't leave the patient. We want to time, when were they last normal? You got to kind of figure out when were they last normal, because the nurse is going to need to know that. And again, don't leave the patient. Send someone to get the nurse. Stop feeding the patient if they're having signs of a stroke. If they are choking, if they're coughing, let them cough, because they will hopefully be able to dislodge it themselves. We don't really intervene other than being there if they're coughing. But if it's a complete obstruction, no breath, no sound, starting to turn colors, we have to jump in and do an abdominal thrust. If the patient is having trouble breathing, you want to get them sitting upright. Again, don't leave the patient. Send somebody to notify the nurse. Good? Any questions? Oh, bleeding. Pressure. Pressure with bleeding. Don't leave the patient. Get somebody to go get the nurse. And burns. There's a lot of, this is kind of surprising to me, but with burns, there are a lot of very wrong, a lot of wrong information out there. We do not put butter on burns. We do not put Vaseline on burns. We cool the skin with cool water, not ice cold. You don't want to put their arm in a bucket of ice water. You want to cool the skin, because it's like when you take something out of the oven, it will continue cooking because that heat is inside. Well, that's what we want to prevent. So we want cool water to help reduce the inside temperature so we can stop that burn from continuing. But don't put anything else on it. Don't leave the patient. Go notify the nurse.
I have a question about the ice. Wouldn't it, like, ice would be cooler, wouldn't it? Like,
No, you don't want to cool it down too rapidly. So we want to cool it down, but you don't want to do it too rapidly, because when you go from extreme heat to extreme cold, that can actually affect the cellular integrity. It can actually break open your natural cells. We don't want to do that. So we don't, it's like when you take metal really hot and then put it in really cold, it can actually cause cracks in the metal. Same thing with your windshield, right? So anybody live up north? Okay. When your windshield ice is over, you got to get rid of the ice to be able to drive. You don't want boiling water. If you put boiling water, the windshield can crack, right? So kind of the same idea. We want to cool it down, but not, not rapidly.
would you get like a cool wet washcloth?
Yes.
Or would you get a basin?
Yeah, it depends on the situation, right? If I can get the patient to the sink, we're going to the sink, because I want that water running. If I can't get the patient to the sink, then I'll get a cool cloth to start with, so they've got something on there while I'm filling up a basin, because filling a basin takes time. So if I can get the patient up into the sink, that's best case scenario. Okay, good. So that's how we handle emergency situations. Anybody do the game show yesterday? Anybody watch the game show? Okay, the game show, I did questions on supplies. So what supplies would you need for certain skills? And I also put some questions in there on patient positioning. So the difference between prone, supine, lateral, Sims, Fowler's, and Trendelenburg. And yes, you will need to know those. You will go over that this weekend in Chapter 9. All of those positions are going to be discussed in Chapter 9. Make some flashcards for those, but they're not too terribly difficult. Prone is laying flat on your stomach and everything is straight. So arms are straight, legs are straight, flat on your stomach. The way I remember that is prone is posterior up. Supine is exactly the same. Laying flat with arms and legs extended, but this time you're on your spine. Supine is on your spine. Prone is posterior up. Same body mechanic. So arms at the sides, legs extended. It's just one on your stomach, the other on your back. Fowler's is a sitting position. Sitting position. Now, there's two different types of Fowler's. There's high Fowler's, which means sitting all the way up. You guys are in a high Fowler's position. There's semi Fowler's, which is a little reclined. So head of the bed just a little bit up. So they're not laying all the way down. They're not sitting up all the way up. That's just kind of a semi Fowler's position. A Sims position is the patient laying on their left side with their right knee bent and up. I call it the sleeping position because it's how a lot of people, side sleepers, sleep, with one leg up. But specifically, they're going to be laying on their left side with their right leg up. And that bottom arm shouldn't be underneath them. It should be slightly behind them. So they're not laying on that arm, but it is extended. And Trendelenburg is a supine position. So laying flat on your back, arms and legs extended. But instead of the bed being like this, the bed is like this. So head down, feet up. So it's a tilted supine position. Yep. So Trendelenburg, think T. Trendelenburg is tilted. Okay. So that's how I remember. I'll give you kind of my memory prompts when I was in school. Do you guys, now this is very old fashioned, but do you know the other word for chicken is fowl? Okay. The other word for chicken is fowl, F-O-W-L. So high fowlers is the position you need to be in to eat chicken. Okay. Fowlers, fowl is chicken. So we got to be sitting up to eat. Sims is the name of a mattress company. And that is a side-lying sleeping position. So Sims is the sleeping position. Prone, posterior up, supine on your spine, Trendelenburg tilted. That's how I remember all of them. Okay, good. You may have one question on the state exam, just one. They aren't really focusing on positioning. The whole purpose here, and this is super important, guys, if you don't know what something means, you need to ask. Don't be afraid of looking stupid. A lot of people won't ask because they don't want to look stupid. If you aren't sure what Trendelenburg position is, you should ask, hey, don't remember what this is. What position do you want the patient in? And they'll let you know. But the worst thing to do is fake it. I'm going to tell you a story about that later today. If you don't know what something means, we have to ask. Don't fake it. Okay, good? Good. All right, so we follow the care plan, or we tell the nurse, unless it's an emergency, and then we have to act and get somebody else to go get the nurse. Don't leave an emergency patient alone. Can you imagine how frightening that would be? If you're having an emergency and somebody starts to work on you and then leaves?
So we would just like press the call light or yell? Or
You're going to yell. Yeah, don't press the call light because you guys are the ones that answers the call lights, and that's not really going to help. But in a clinical setting, a lot of settings have specific words that staff members use to summon other staff. So you'll want to find that out during your orientation period. If I need help from staff, what do I call? A lot of times you don't want to call help because your patients are all yelling help, and that's not helpful. So usually we'll use a word like staff. Staff, room 212, staff. We can also, there's different codes that are used in different facilities, like Dr. Strongarm is one that is used occasionally when we have a combative patient. And, you just yell, Dr. Strongarm. And what that's calling for is security. So they'll go over those things with you in during your orientation. This is becoming more, the security thing is becoming more and more relevant because, unfortunately, there's a lot of like crazy people out there. And sometimes they try to injure healthcare workers. So this is affecting staffing. A lot of facilities are now having to reevaluate staffing needs and not leaving like one caregiver in a unit, because if a patient starts to get combative, that person has nobody to call for help. So they're looking at this. I don't think they're looking at it enough. I really don't. I think that this is the new crisis that's going to need to be solved. But pay attention during orientation. Pay attention. All right. So that is skill rules. Every skill starts with the opening. Every opening starts with a knock. And then we're going to address our patient by name. Hi, Mrs. Jones. For the test, everybody is Mr. or Mrs. Jones. Make it easy. And then you're going to introduce yourself by name and title. They need to know who you are before you can work on them. Don't just assume because you're in scrubs that they're going to trust you. Anybody can buy scrubs. They sell them at Walmart. They sell scrubs at Walmart. You don't have to prove you're a medical professional to buy scrubs. So just because somebody has scrubs on does not mean they're a medical professional. So your patients know that. They're not going to automatically trust you just because you're in their room dressed like a healthcare worker. You need to tell them who and what you are. I'm Patty, your CNA today. Guys, this has happened. As crazy as that sounds, this has happened. There have been many, many cases of people that portray themselves as medical professionals. They throw on a lab coat, a stethoscope, and they start making rounds, and they don't work there. They don't. Oh, yeah. Yes. Yes. They would need a psych consult for sure. For sure. Yeah, absolutely. Well, I mean, look at what was that one Leonardo DiCaprio? Catch Me If You Can. Yeah. That was one of the jobs he pretended to be. Yeah. And that was a true story. Yeah. So amazing what some people will do. So we need to make sure that we're identifying ourselves appropriately. And please, I know that ID badges are horrible. I know that nobody takes a good picture for an ID badge. And I can't tell you how many times in a clinical setting, ID badges are purposefully turned backwards. That is not a good practice. And if you get caught by every facility is going to have an inspection every 2 years. If you get caught with your ID badge not displayed properly, it can be a fine for the facility because it's not about you. It's about the patients. Once we have identified ourselves by name and title, we'll describe the skill, we'll get permission, and then we can close the curtain, wash our hands, and get our supplies. One of the supplies we may need is gloves. Maybe. You don't need gloves for every skill. How do we know when we would need gloves? Okay, personal skin, body fluids, and non-intact skin. So sores, wounds, rashes, incisions. Non-intact skin. Okay. First thing your gloves should touch is the patient. So keep your gloves clean. Pay attention to what you touch in the environment after touching the patient so we don't grossly cross-contaminate. And then you need to know how to remove your gloves correctly. Dirty glove cannot touch skin. If we're going to use supplies, we need a barrier to put them on. Now, that barrier is the first thing we get. So once we wash our hands, we're going to go get that barrier, put it on our table, and then go back and get the rest of our supplies. Good? Good. It gives us a clean area to put our clean supplies. One of the supplies we might need is a privacy blanket. If your patient's going to be uncovered or undressed at any time, we're going to use that privacy blanket to keep them warm and protect their privacy. But when we put it on, we don't snap it or shake it. We're going to put it on top of the sheet and pull it down underneath. If we use a privacy blanket, we remove it after we remove our gloves. Good? Good. Linen rules. Linen rules are repeats of what we've learned so far. We don't allow linens to touch our uniform. We have to have clean hands to get our linens. You don't snap or shake the linens. Clean rolls toward me, dirty rolls away. We don't let anything touch the floor, not clean or dirty, and anything we take and don't use, we have to discard. Patients must always be in the center of the bed. We don't always have side rails to keep them safe. So if we're turning them, they have to be in the center of the bed after the turn. That means we're going to scoot them toward us and then roll them away. We always roll away. If we're going to wash anything, lots of rules here. We don't add soap to the basin. We need water for rinsing. We use a paper towel to turn the faucet on because you don't want to touch a faucet with your clean hands. We're going to check the water with the inside of our wrist. Should feel warm, not hot, not cold, just warm. And the patient's going to check the water as well. If that water gets cold or soapy during the skill, change it out. There's no time requirement here. The evaluators aren't going to look at the clock and say, okay, it is 9:28 when she got the water. They don't do that. But pay attention. Your hands are in the water wringing out those washcloths. If it feels cool to you through your gloves, it's definitely cool, right? So pay attention to that. Let's see here. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to use the leaves method for wet body openings. Don't get your surface wet, and warm up lotion before you put it on and wipe off the excess. All basins are cleaned the same way. You rinse it, you dry it, you store it. That's all they're looking for the test. We rinse it, we dry it, we store it. They don't care how that happens. But if you have dirty hands or dirty gloves, you cannot touch the outside of this drawer. We can't contaminate it. So we need a paper towel to open the drawer. I want you to learn this process so that if you do have to disinfect, we have one process that allows for disinfection. So for the test, rinse, dry, store, use a paper towel to open the drawer. That's all they care about. For me, I want you to know that you dump it, rinse it, dump it, set it down, spray it if necessary. Paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and then one more for the drawer. Good? Good. Shoe rules. If the patient's feet hit the floor, we have to talk about their shoes because slipper socks are not enough. If you have a skill that requires you to get the patient out of bed, so ambulate, transfer, which we're going to do today, we have to make sure that we are keeping the patient safe. Slipper socks are not enough. So for a lot of skills, your patient will already have shoes on, but the one we're doing today, we have to physically put shoes on. If we're going to use a gait belt, we check it to make sure it's snug enough with 4 fingers. Before we lift a patient, we have to make sure their feet are flat on the floor. And when you're going to stand them up, you want to count to 3 so that it makes them a partner. So 1, 2, 3, we stand up and we're going to let them acclimate a minute. Stand for a second before we go walking. Ask if they're okay before we get away from the chair. When we return the patient back to the chair, you want to turn them around and back them up so the backs of their knees hit that chair before we sit them down. And make sure you use that body mechanics, that oblique angle that I showed you for body mechanics to keep your back in good condition. And then every skill ends with the closing. Oh, that's the TV. The TV is on mute. Yeah, that's fine. We'll fix that. Thank you. Thank you. Let's do a mic check. Guys, virtual guys, can you hear me? If you can hear me, let me know in the chat. Give me a thumbs up or let me know in the chat. Every skill is going to end the same way. We're going to ensure a clean environment. So take a look around. Make sure your patient looks better than you found them. Thank you. Bed height must be in the lowest positions. Let's talk about that real quick. For the test, you're not required to raise the bed up to do any skill. You're not required to. You can leave the bed in the low position for everything you do for the test. No problem. But if you do raise the bed, you have to remember to lower it at the end. Now, I'm editing the new videos and I was working on one of the range of motions yesterday. And I happened to notice as I was sorting through all of the video footage to compile all of the scenes, in that video that my body mechanics, I'm sure I don't really think much about bending over the bed, but as I was looking at that, I actually could see from outside looking in how much I was bending and how much pressure that's putting on my lower back. Now, over time, that's going to, cause a lot of back strain. So use the bed. If you have a bed that goes up, use it to keep your back in good working order. You don't have to for the test, but kind of be aware of those body mechanics because you've only got one back and it's kind of have to last you your whole life. You don't want to destroy it early. We're going to ask the patient if they're comfortable. We're going to offer a magazine for emotional distraction. We will adjust the head of the bed if requested. You're going to open the privacy curtain and give the patient the call light. We don't care what order you do those things in. Don't care. Don't care. Clean and safe environment, bed in the low position, call light, curtain, comfort. We don't care. Make sure they're covered too, either with clothing or a sheet. I don't want to see their knobby knees. Once you get all of that done, we don't care what order it's in, just get all of that done, then go clean your hands. If you have to document, documentation happens after hand washing. But our rule here is to end skill with clean hands. So if we document, we have to wash our hands again. Good? Do you guys have a pretty good, strong understanding of those 11 principles? This is why it's so important. In this program, I am teaching you 21 skills. So hand washing and 20 others. That's what I'm teaching you. After today, we only have 3 left. So we're on a good track here. But those aren't the only skills that you will have to do as a CNA. When you get out there and you start working, you may be asked to learn additional skills based on the setting that you're in. The thing about that is that all of these rules will apply to any new skills that you learn. That's why we have to really, truly understand these principles because these are best nursing practices. They apply universally. It doesn't matter whether you're in Idaho, Iowa, or Hawaii. If you're going to uncover the patient, they need a privacy blanket. Make sense? So you've really got to understand these because they will apply to any new skills that you learn. Now, we're going to get into skills specifics. And I'm just going to go through this really quickly. You can watch the videos again on how these are done. And as we go through this, you're probably going to think, oh, yeah, I remember that one. Oh, I forgot about that one. I remember it now. That's why we do these reviews because I'm shoving so much new information at you that it's really easy to kind of forget some of the things that we went over before. So with a pulse, this is a radial pulse located at the top of the thumb side of the wrist. And we always report it over 1 minute. So a pulse rate, if I tell you it's a pulse rate of 72, that means that heart beats 72 times a minute. Okay, it's always reported over a minute. Doesn't mean we have to count for a minute. We count for as long as care plan tells us to. But it's always reported over a minute. So if you count for less than a minute, we got to multiply that by whatever we need to get it to a minute. So if you count for 15 seconds, you have to multiply that by 4 to get to your minute. If you count for 30 seconds, you got to multiply that by 2 to get to your minute. Make sense? Normal is between 60 and 100. If we get anything outside of that range, we report it to the nurse. We do not use our thumb to take a pulse. We use 2 fingers, and we want to use the fingertips, not the flat part of our fingers. We're going to say start and stop so that the evaluators know when to start counting and when to stop counting, and hopefully they get the same number. But you can be off by 4 beats in either direction and still be okay.
What if during the test, the person's pulse is out of range?
Okay, so great question. So a couple of things about that. I'm going to answer a question you didn't ask as well.
Okay.
So let's say during the test, because the person you're doing this on is another testing student, chances are they're going to be pretty anxious because they're being tested too, right? So chances are their pulse is not going to be really chill. And you might get a pulse rate of 110 because anxiety. For the test, you're just going to document it. You don't have to do anything else. Now, I would, at the end, say, I would report this to the nurse. It's abnormal. You don't have to, not a graded checkpoint, but I certainly would take that extra step. Now, a question you didn't ask, though, but is still very important. What happens if you lose the count during the test? Very common. Especially if you don't have your thumb on the back side of the wrist. Remember, we talked about that thumb, right? If you forget to put your thumb on the back side of the wrist when you're taking the pulse, if you just have your fingers there, your fingers are going to relax. You'll lose the pulse every time. So if you forget to put your thumb back here to get that consistent pressure, you'll get about 20 seconds in and you're going to lose the pulse. Don't fake it. You're going to tell the patient, remember the evaluators don't count in our book. You're going to tell the patient, oops, sorry, lost the pulse. Let me try again. I got to start over. Oops. Oh no, my mind wandered. Hold on, let's start again. However you want to say it is fine. Those evaluators are pretty smart cookies. They'll keep up. But you want to address all of your communication to the patient. Good? Can you imagine how upsetting it would be if you were in the let's just pick on somebody in the hospital right now. They're scared, right? If a patient in a hospital, they don't know what's going on with them. They're sick enough to be in this place. They're not home. They're surrounded by strangers. They're scared. Now, imagine two strangers standing on either side of your bed that are talking to each other and totally ignoring you. Oh, really scared because now I'm no longer human. Right? They're not treating you like a basic human. They're treating you like a lump of flesh that has no brain cells to understand what they're saying. And that is not the impression we want to give. Make sense? So for the test, do not forget that this is your focus, not that evaluator. But more importantly, when you're out there working, please remember that this is your focus, not your coworkers. And this happens way more than you think it does. Healthcare workers will come in and they'll talk to each other and totally ignore the person they're working on. That's not how this is supposed to go. Good? Make sense? Okay. Glory, I passed the CNA exam yesterday, both written and practical. Thank you for all you do. You're a great teacher. Congratulations. Oh, I'm super proud. Great job. Peace. Good morning, Miss Patty. Thank you. I passed my CNA exam with your skills. Congratulations, Peace. That's awesome. Awesome. I love those. Those make me feel so good. Thank you guys for letting me be part of your journey. All right. So dressing a resident, we want to ask the patient what they want to wear before we get them undressed. Don't undress somebody, leave them there naked while you go find their clothes. That's just icky. We're going to ask what they want to wear. You'll get the clothing before you undress them. We're going to lift from below with a flat palm, support all joints. We undress the strong arm first. We dress the weak arm first. They don't care how you put the socks and pants on, whatever you want to do. I don't care if you put the socks on first or the pants on first or the shirt. Nobody cares. Just get them dressed. It's the shirt that we're worried about because the way we dress somebody with a weak arm is going to matter. Okay. Just don't forget to put their pants and their socks on. Don't overextend or force movement. We're going to just adjust the clothing for neatness and appearance. We put the dirty items in the hamper and call light in the stronger hand. Hand and nail care. We support the wrist and arm at all times. We're going to soak the hand in water take it out and put it on a towel to wash. Put it back in to rinse, take it out to dry. Once it's dry, we'll clean under the nails with an orange stick, wiping in between each nail. File the edges in one direction toward the center, and then we'll warm up some lotion, put it on, and wipe off the excess. That's a whole skill. Well, we have quite a few people on. Those of you who are joining us from classrooms, if you are going to host a state this week, I will be there on Friday. Come see me at the booth. So if you're going to HOSA State Leadership Conference in Orlando, I will be there on Friday. Make sure you stop in. Okay, that's hand and nail care. Gina, Miss, oh, I like Party. Miss Party, I want to take the test. What do I have to do? Well, you'll have to register for the test, Gina, and it depends on what state you're in. If you're in Florida, you can go to my website. We'll put that in there for you. You can go to my website and get the test registration instructions to register for the test. If you're in any other state other than Florida, you have to take a class that's licensed by the state to be eligible to test. So I'm not sure where you are, but you need to register for the test. And in most cases, you have to take the class. All right, make an occupied bed. You're going to change the bed a half at a time. Make sure the patient doesn't fall off the bed. That's really what this is about. It's not really hard. The way we do this, though, is clean rolls toward me, dirty rolls away. You want the patient on their side in the middle of the bed when you're doing this so they're not taking up so much of the mattress. People take up way more of the mattress when they're laying on their back, right? This much on your back, this much on your side. So you want to scoot them towards you, get them on their side, change that bottom sheet, clean rolls toward me, dirty rolls away, and then put them back on their back, go around to the other side of the bed, repeat the whole process. Scoot them towards you, turn them away, remove the old sheet, put the new one on. That's it. And then, easy, we put a top sheet on, get the corners under the mattress, make hospital corners, and change out that pillowcase. Try to keep them covered while you're doing this. Try to keep them covered with a privacy blanket. It's okay if the privacy blanket slips a little bit and we catch some skin, but we want to try to prevent unnecessary exposure whenever possible. Have you guys ever, trying to give you an analogy that would help you make sense. Have you ever seen a car that's been painted like really well? Like has an amazing paint job, right? And it catches your attention, doesn't it? Because it's an amazing paint job. Now, every car is painted. Every car is painted. But some of them are just amazing, have nice details, some graphics, whatever, right? So even though every car is painted, there are differences in quality that can be seen. Does that make sense? This is the same thing. The way CNAs do skills, right? Every CNA can make an occupied bed. This is something you learn. Every CNA can do this. Your quality is going to shine through in the details. If you keep your patient covered, that shows your quality. Does that make sense? And it kind of makes all those other paint jobs look very basic. The better you care for your patient, the better CNA you will be perceived as. Does that make sense? I should do a lesson on that. You guys want to get paid more, right? Part of that is looking professional. They're not going to pay you as a professional if you don't portray yourself as a professional. So all of these little things that I'm telling you are all there to help you elevate your quality as a CNA. Side lying position. This is when we have to turn somebody. If somebody can't roll on their own and we're going to turn them, we're going to set it up a very specific way. We'll scoot the patient toward us first. However, we're going to do that. Either we're going to move them in segments or use the draw sheet or ask them to slide over, whatever that patient needs. And then furthest arm goes up, closest arm crosses over, closest knee bent, furthest knee angled. And then you just roll. Super easy, way easier than you think it is once you get them set up right. Way easier. Always turn the patient away from you. We'll put a pillow behind their back to keep them there. Put a pillow between their legs. Put a pillow under the upper arm and adjust that one under the head. The call light will go in the bottom hand. And the reason for that, you don't want that call light cord to go across the patient's neck to put it in that top hand. Foot care, just like hand and nail care, a little lower. Soak the foot, take it out of the basin, put it on a towel to wash it. Put it back in the basin to rinse, take it out to dry. When we dry, you want to blot between the toes with an edge of the towel, and then we're going to apply lotion. We don't do anything with toenails, nothing. Just look at them. If the patient needs some attention, we'll relay that on to the nurse. Put lotion everywhere but between the toes. Put their shoe and sock back on and clean up. That's a good question. International applicants. In some cases, we are not set up to help you with that, but there are some agencies that do, that recruit people internationally and get them set up for their class and to get their work visa and their social security number, because you have to have a social security number in order to test. This is all state specific, so I can't give you specific details. It would depend on the recruiting agency that you're looking for, that you're working with. Mouth care. Patient must be sitting fully upright. That just makes sense. We're going to put a towel over their clothing. We'll wet the toothbrush before we put toothpaste on it. We're going to wear some gloves and we're going to brush whatever they got. Let them rinse and spit as often as they need to. Make sure their mouth is dry. And then just clean up. That's it. Respirate. Boy, we've learned a lot. Respirations, don't tell them you're counting their breathing. You want to pretend you're taking their pulse. Again, it's always reported over 1 minute. Normal is between 12 and 20. We're going to say start when we start to count, stop when we stop counting, and we can be off by 2 breaths in either direction. Well, this is a documentation skill. Range of motion. Remember that CNAs do exercises to retain function. It means we're trying to keep what they've already got. We're not making anything better here. We're going to follow the care plan. Care plan will tell us what body part, what exercises, and how many repetitions. We lift from below with a flat palm, 2 points of support near the joints. Return all the way to the start position and move slowly and smoothly. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. And you want to pay a super close attention to your care plan to know which exercises you're going to do. Dentures, just like mouth care with an extra step. So denture care has 2 parts. We're going to clean the dentures and we're going to clean the mouth the dentures came out of. When we're cleaning the dentures, you have to have gloves on to handle dentures. You want to put a washcloth in the bottom of the sink, so if the dentures fall, they don't break. You're going to use a denture brush to clean the dentures. The small end goes in the channel. The big end looks like a toothbrush you use on the teeth part. Keep the dentures over the sink and use cool water. Once you're done cleaning the dentures, you'll rinse out the denture cup, fill it up with cool, clean water, put the dentures back in, and put it on a coaster on the bedside table. Once you're done with cleaning the dentures, put the washcloth in the dirty linen hamper. Bring your basin with your denture brush back over to the table And then you can remove your gloves and start on the mouth care portion. We also learned how to ambulate with a gait belt. This is simply walking. We want to look for obstacles before we stand the patient. There will be an obstacle. You want to apply the gait belt before you lift the patient. This just cracks me up. Remember I said that everything here is a checkpoint that gets missed? That's why they made it a checkpoint, right? It really should be kind of self-evident that you put the gait belt on before you stand the patient up. That does not happen always. There are some people testing that will stand the patient up and then put the gait belt on. Not sure what they think the gait belt is doing. We put the gait belt on over the clothing while they're sitting, and we use that belt to stand them up. Okay? You're going to help them by holding that gait belt on their back in an underhand grip to feel for any instability, any slowing. We'll let the patient lead, and we're going to walk slightly behind and to one side. Your total focus should be on the patient. We want to ask them how they feel periodically. We'll assist the patient to stand and sit, and we're not going to pull that gait belt against the skin. And the last skill that we've learned is partial bed bath. With partial bed bath, we're going to wash face to waist, front and back, and one arm. Face first, no soap on the face. So we're going to rinse and we're going to dry, but we're going to use that leaves method on the face because we have wet body openings. And then we're going to wash whatever the care plan told us to, which is neck, chest, abdomen, side, one arm, and hand. Change the gown out, turn them on their side, scoot them towards you first, turn them on their side, wash the back, rinse the back, dry the back, little lotion, warm it up, little back rub from bottom to top 3 times, wipe off that lotion, tie the gown, clean up. Long skill, 19 minutes, long skill. It shouldn't take you 19 minutes to do it, but that's what they're going to give you. I think my video takes 12. Okay, good. Whew. Moving on, page 72. This is very, very similar to ambulate with a gait belt. Very similar. We're going to use the same body mechanics. We're going to count to 3, just like we did with ambulate. We're going to put the gait belt on the same way we did with ambulate. So this is a very similar skill to ambulate. You want to make sure they can feel the chair behind them before we help them sit. Very similar to ambulate. There are a few differences, though. So if you look at the principles involved in this skill, down the side, they're all spelled out here. Not a whole lot to learn. We know all of the principles involved in this. We just have to learn the skills specific now. I have a video. Down here is test specific information. Somebody with your level of experience should be able to do this skill in 11 minutes or less. Guys, we're getting somebody out of bed and putting them into a wheelchair. And they're giving you 11 minutes to do that. That's way more time than you need. Way more time. This is done on a live testing student. If you are the student for this skill, if you're the patient for this skill, they're going to give you some very specific instructions that you have to follow. I'll get into those instructions in a minute, but this one is going to require you to kind of pay attention to detail if you're the patient. Actually, all the skills I'm doing today are like that. That person will be positioned in bed to start with because the whole point is to transfer the patient from bed into the wheelchair. So you'll have a live patient laying in bed. We got to get them out of bed and into the wheelchair. The resident is unable to walk or take steps. I want you to underline that or highlight it. The resident is unable to walk or take steps. Jake, go get me the wheelchair, please. Care plan also tells us the patient can stand with support. So you're not holding their whole body weight. They can stand, but their feet don't work. Now, this is super important. I told you guys that, thank you. Perfect. Thank you. I told you guys that if you're the patient for this, you're going to get some very specific instructions. These are the instructions you're going to get. You cannot take steps. You cannot take steps. So when we're transferring a patient out of bed and into the wheelchair, if they cannot take steps, take a look at this graphic here. If we stand that patient up, this foot right here, this far foot, do you see how far that foot is away from that wheelchair? If we stand that patient up there, they're going to have to take a step with that foot to get into the wheelchair. So even as close as that wheelchair is, it's not close enough. Good? Make sense? When we are going to transfer a patient from bed into that wheelchair's got to be pretty much touching them. That's how you keep them from taking steps. Amy says, hi, Miss Patty. Such a great program available. I love the flashcards. They're super helpful. Thanks so much. Thank you, Amy. I appreciate that. Awesome. I'm glad that they were helpful. Okay. Go ahead and take that down, Jake. These are the supplies we need. Oh, let me go back to the care plan. It says a gate belt or transfer belt is required to transfer the resident, and the resident will stay in the room. These are the supplies. Not too much for this skill. But I want to talk about that last line. The resident will stay in the room. This isn't the end of the patient's day. This is one scene out of their day. If we're getting somebody up out of bed and into a wheelchair, chances are they're going somewhere. That's the whole point of a wheelchair, is to make them mobile. Take them somewhere. Now, this scene is going to end with them staying in the room. That doesn't mean the patient's always going to be in the room forever and ever. It just means that right now, the patient's going to stay in the room. Put them in a wheelchair, leave them there. But do you think that patient wants to be staring at a wall? No. In fact, that used to be a common punishment years ago. We'd put people in the corner and make them stare at a wall. That was a punishment. So if we put a patient into a wheelchair and leave them staring at a wall, they may feel like they're being punished. So even though our care plan tells us the patient will stay in the room, our job is to recognize that they need something to do while they're staying in the room, and we're going to turn that wheelchair around so they've got something to look at. TV, window, doorway, roommate, something, not looking at the wall. So part of this skill you're going to see, I turn the wheelchair around so that the patient isn't staring at the wall. That is actually a much more important step than you think it is. Because we're not just treating the physical patient, we're treating the patient emotionally as well. Help if it doesn't help. Good? All right. I've bolded this for you. The patient cannot take steps. Super important. But to understand how to do this skill, we have to learn our equipment. So that's what we're going to focus on now. To review shoe rules real quick, if the patient's feet hit the floor, we talk about their shoes. Now, this patient's laying in bed. Nobody in bed has shoes on. So when we get them sitting on the edge of the bed, they are not going to have shoes on. We've got to take the time to put shoes on that patient. When you get signed in for the test, when you come into the testing center, they look at your IDs. They ask you, do you have any conditions that would prevent you from being a patient for any one of these skills? And you're going to say, no, I'm good. One of the things that they're looking at is your overall appearance, your body size, your level of ability, and your shoes. Believe it or not. They are going to look to see who's got shoes at a glance that just kind of slip on, don't require tying. So if, let's say, if you get transfer from bed to wheelchair, I'm looking for somebody about your body size or smaller that has slip-on shoes. We're going to make this as easy as we can for you. Do your shoes just slip on? Okay, so you would probably be matched up with her for the test. Does that make sense? Okay. Sometimes it doesn't work out that way. Sometimes you'll have to tie shoes, you know, and that's okay. But they are trying to make it as easy as possible and reduce the amount of time these skills take. Where do they want to be? At home in their pools, drinking their margaritas. They don't want to be watching you tie shoes and struggle with all of that. They test 7 days a week, and they only take off major holidays. So Christmas, New Year's, Thanksgiving. Absolutely. Memorial Day, 4th of July, and Labor Day. Those are the only holidays. So Good Friday coming up, yeah, they'll be testing. Easter Sunday, I still think they test on Easter. They test 7 days a week. Now, every testing center, you guys remember that application packet I gave you? Remember those 2 pages of testing centers? Each one of those testing centers tests a minimum of 8 people a day, 7 days a week. So each one of those testing centers is testing 56 people a week, minimum. So that should tell you, it should give you an idea of how many people we have testing. And they are always packed. The industry is kind of transient. People get in and then they get out. And then they decide they need money, so they come back in and then they get out. It's just like this revolving door. But they test a lot. So we don't want, this patient will be laying in bed with socks on. We don't want to transfer this patient with just those socks. Putting shoes on is going to be a critical safety checkpoint for the exam. Good morning. I have a question, please. If I live in Miami, what can I do to take the exam with 4YourCNA, please? Oh, that's a good question. We don't actually give the exam. We are training you for the exam, but we don't administer the exam. So everybody in Florida has to test through Prometric. Our website does have detailed test registration instructions. So you would want to go to our website and look at the test registration instructions and register for the test. But we don't give the test. I just demystify the test for you. I make sure you pass. All right, so we're going to put shoes on the patient before transferring. I'm going to tell you this just, I've been doing this a long time, guys, a long time, like 17 years. I've been doing this for a long time. And I hear all kinds of stories. Well, there was a testing center in our geographic area that apparently heard me at some point, or a training center, I'm sorry, not a testing center, a training center, another school, that heard me at some point say this: if the patient's feet hit the floor, we talk about the shoes. And they started training their students to put the shoes on while the patient was in bed, so their feet did not touch the floor. How many of you guys want shoes in your bed that you're going to sleep in? Yeah, that's not how we do this. It's okay to get the patient sitting on the side of the bed and then get their shoes on like normal people. Don't put their shoes on in bed. Yes. Yes. And I was actually contacted by a couple of, this is when we were a testing center. We actually did the test here for several years. But yeah, I was actually told this by a 2 or 3 evaluators that were testing, and they said, yeah, we're seeing this a lot. So I started asking the students, where did you go to school? And then I contacted the school and said, okay, let me clarify this, because I don't know that I was all that clear. We don't want to put shoes on while the patient's in bed because that soils the sheets. Okay. All right. Yep. No, that's good. That's good. So we want to put the shoes on before we put the patient on the side of the bed. Remember, slipper socks are not enough. There are going to be periods there. There's going to be patients that aren't going to have shoes. It happens. It does happen. You will have some patients that you're caring for that either don't have shoes or their shoes aren't comfortable or they're too swollen to put shoes on. There's a lot of reasons. And they may be more comfortable in slipper socks. I want you to remember that shoes do two things. They protect against injury, but they also minimize pathogen transfer to the sheets because the pathogens are on the shoes that don't get into bed with the patient. Make sense? So if you have a patient that prefers socks, who do we tell? We tell the nurse. But we have to remember, okay, I can't put shoes on my patient. I've told the nurse, but I have to remember now that shoes do two things: protect the patient and prevent pathogen transfer. So what am I now responsible for? Right. I am now responsible for protecting the patient. So I need to look at that pathway where we're going to walk, make sure there is nothing there that might injure that patient. I now have to be the shoes. And I have to protect against pathogens. So I'm going to take those socks off before they get into bed and change them out. So if your patient can't have shoes, you have to become the shoes. And in order to do that, you got to know what those shoes are actually doing. We let the nurse know. And again, you're going to have to be the shoes. You got to look so close, so close. And the way that I approach this with patients, and my mother is a great example of this. She does not wear shoes in her house at all. And I'm bad about that too. When I walk in my house, I take my shoes off. I mean, it's just how I've lived my whole life. As I'm getting older, I'm getting more knee problems, more feet problems, and I'm finding that shoes are actually helping with that, kind of keep me in better alignment, right? But I talk to my mom about this all the time. Mom, you really shouldn't be walking around your house barefoot. What if you step on something? And she's like, yeah, but it's just more comfortable. She always, not fights back, but, okay, that's fine. But remember, there's some risk there. So what I tell patients, I've told my mom this as well, if you would not be comfortable with a child, a toddler, barefoot on this floor, you should not be comfortable with you barefoot on this floor. So you have to think about the floor. In a hospital, would you be comfortable putting a toddler without shoes down on a hospital floor and letting them walk? When you pose it that way to patients, it overcomes their objections. Because they start to think about, okay, why wouldn't I be happy putting a toddler on that floor? And do I really want to come into contact with those? So it starts their mind working in that way. So that's what I use in a clinical setting. Would you be comfortable with your grandchild walking on this floor without shoes? And almost universally, they'll go, well, no. So do you really want to walk on this floor without shoes? Oh, yeah, I guess you're right. I'll take those socks. Thanks. And I can at least get socks on them. Okay. Good. Yep. Chrissy. Hi, Chrissy. I am trying to purchase the flashcards and it's telling me to create an account password field. I'm in New York. You shouldn't have to, it'll ask you if you want to create an account. That way you can review your purchases and download your receipt and all of that, but you should be able to skip that. You should be able to skip that if you don't want to create an account. If you create an account, you're able to review your purchases. That's all. Okay. Gait belts go around the patient's waist. We check them with 4 fingers. We make sure the patient's feet are flat on the floor before we stand them. We count to 3. We're going to stand at an oblique angle for stability. Once we get them standing, we're going to turn them, pivot them, and we want to make sure they can feel that chair behind them before we sit them down. I'm going to tell you a little secret about that. And I want to talk to you guys about skill-specific steps now. Remember, this patient's unable to walk or take steps. Now, here's the problem. Our care plan told us that our patient cannot walk or take steps, but can stand with support. So I'm not holding that patient for very long. However, if I get this patient standing and I pivot them, and even if the wheelchair is right there, I pivot them, I'm holding them. Do you know how long I'd have to hold that patient to say, hey, can you feel that chair behind you? And they have to think about it. And then they say, yeah, I can feel it. And then I lower. That's a long time to be holding a patient. I don't do that. Now, I know they have to feel that chair behind them, but I don't wait until we're standing there to ask. What I do is prep my patient. I'll get the patient sitting on the side of the bed, get their shoes on, gait belt on, we're ready to go. Feet are flat on the floor. I am in position, and I'm going to tell this patient, I'm going to pivot you around. When you feel that wheelchair behind your legs, I want you to say sit. And I'll reach my hands around the gait belt, have them put their hands on my shoulders, and I'll remind them, when you feel that chair, say sit. 1, 2, 3, up, over, down. I'm holding that patient a whole lot less time. If you do this, 1, 2, 3, up, over, can you feel that chair behind you? Sit. That's a long time to hold somebody. Now, I know this patient can stand. Care plan said they could, but you're still going to be bearing some of that weight. Good? Make sense? Prepare your patient. When patients know what to expect, they generally will cooperate. This, however, is not a good position for that wheelchair. It's got to be way closer than that. But this patient's laying in this bed, in order to get them pivoted around so they're sitting on the edge of the bed, I can't have that wheelchair there yet because they'll run into the wheelchair. So the wheelchair is going to be far away from the bed. We'll get the patient sitting, and then I'm going to pull that wheelchair close once the shoes are on and the gait belt's on. Now we got to talk about wheelchairs. So this is wheelchair 101. Wheelchairs are usually kept in the folded position for storage. When we have a wheelchair in the folded position, takes up less room, but we have to know how to open it up for patient use. So we want to get those big wheels off of the ground. Hey, Jake, can you, let's try follow me. I don't know if follow me will work, but let's try follow me.
What? I think it's trying to lock onto the mannequin for follow mode.
Oh, we had that problem before too. She doesn't move. Okay. Nope. Okay.
I don't understand.
I know the follow me thing just doesn't.
Standard reset. Okay. Yeah, sure.
Oh, it's following you. Let me stand here.
Yeah, stand center. Let me get out of
Ow,
frame.
ow, ow, ow.
Here, let me do this. I'm gonna bring it to you.
All right.
I hit follow mode. Let's see what it does. I'll just manually follow you.
Okay. We still have some learning to do with our technology. All right. So you'll have to do the slides for me too as we go through.
Where we at?
Just stay, I'll tell you when.
Okay.
All right, so let's talk about wheelchairs. Wheelchairs are in the folded position. To unfold them, we lift those big wheels off of the floor to reduce friction. So lift up a little bit and just pull the handles apart. They open very easily. If you have an older wheelchair that's a little stiffer, you may have to push down on the bars to get it to completely open. But when you do that, don't have your hands like this on the side. So if this only opened part of the way, and I'm going to press down on these bars, I don't want my hands like this because it will pinch me. I want to keep my hands up and press down. Good. Now brakes. If a wheelchair is not in motion, the brakes should be on. So these are the brakes right here in front. You can see it on the screen as well. This, the brake is not engaged. There's a gap between that metal and the wheel. Brake is not engaged. This one, the brake is engaged. So every wheelchair works a little bit differently. Some you push the levers forward, some you pull the levers back to engage the brake. Doesn't matter. What we're looking at is this right here, this metal tab. You guys see that metal tab? That metal tab, when it's biting into the wheel, the brake is engaged. Okay. So over here, this metal tab, the brake is not engaged. There's a gap. If I pull this back, it's biting into the wheel. Brake is now engaged. Anytime the wheelchair is not in motion, the brake should be on. And that's because floors are rarely level. Concrete floors tend to crack, especially in Florida. Wooden floors warp with humidity and temperature changes. Floors are not always completely level. If we have a body in here with weight in that body and the floor is not level, this wheelchair can start to roll. And the only thing that's going to stop it is whatever they run into, which means our patient is running into something, which is a safety issue. Good. Wheelchair brakes are not restraints. They're within the reach of the patient. The patient can unlock that wheelchair, go anywhere they want to, but the brakes have to be engaged if the wheelchair is not in motion. The other problem is if this patient tries to get up out of the wheelchair and those brakes are not engaged, that wheelchair is going to roll and the patient's going to trip and probably fall. Okay. That could be a test question. All right, Jake, go ahead and advance my slide for me.
Which slide are you on?
It should say on there. There you go. Nope.
It went away.
Hold on. All right.
Sorry. It was
Okay.
marked on there and I hit the next arrow and I thought
Yeah.
it would proceed.
So right here, just so that you know, see where it says current screen
Oh,
on?
that makes a lot of sense.
Okay. So if you look here, look at the lights. Do you see how the lights are kind of warped? That floor is not completely level, and this is a local hospital. It's a local hospital. We don't say names. All right. This is one of the largest healthcare negligence court cases here in Florida. It was very sad because this patient died. And this is one of the reasons why we have this rule. This was a dementia patient who was in a wheelchair. So dementia patient, she was not aware of her own safety. She was able to get into a stairwell because the wheelchair was not locked and she had no awareness of safety. And she fell down concrete steps and ultimately died. So there was a lot of failure here. First of all, the wheelchair should have been locked. Second of all, in a dementia unit, she never should have had access to this. We talked a little bit about that last class, right? So we want to make sure that we don't prop doors open or allow anybody in places they shouldn't be, especially in a locked unit. She was not aware of her safety and she ended up dying. Now, remember, if this patient was able to care for herself, where would she be? Home, caring for herself. The whole reason that she's in our facility is because she needs somebody to care for her. And unfortunately, that was a failure on our part. Does that make sense? Good.
Is that near here?
I'm not sure where this was in Florida, to be honest with you. I just know it was one of the, it's not the largest anymore. I got to change a slide. There's actually been one, not wheelchair related, but there's actually another negligence lawsuit that came in at a higher verdict than this one.
Isn't it
Mostly, but not all. Not all. Hospitals have their share of lawsuits as well. Yeah. Wheelchair brakes are not a restraint. They're a safety measure. Any able-bodied person can undo the wheelchair brakes and go anywhere they want to. It's not a restraint. But if they're not able-bodied, if they can't undo those brakes, that means they can't stop the wheelchair from rolling into something else. Make sense? Okay. All right. All wheelchairs should be locked when not actively in use. Now, let's talk about the height of wheelchairs. This is actually important. And it's not something that you are likely to think about on your own. So if you look at the graphic on the screen there, you can see it's this wheelchair. Again, I take all my own pictures. It's this wheelchair. I've got that chair at my house. But you can see that there's a height difference. Right. So we do that on purpose. The whole purpose of a wheelchair is to take somebody somewhere. It's a mobile chair, right? Which means that we want to take somebody somewhere. We don't want their feet flat on the floor. Because then you'd be, dragging the feet and risking injury and all that. So wheelchairs are always a little bit taller. Why do we care about that? And Jake, can you advance the slide for me, please? We care about that because of circulation. Let me move this a little bit. Down the back of your legs, or actually the middle of your legs, you have an artery that's pumping blood to your feet, and you have veins that are coming back to your heart. Now, all of these arteries and veins congregate right behind the knee. Right behind the knee. And they're very close to the surface. Go ahead and advance my slide one more time. When you're sitting in a chair, that knee is right along the edge of the seat. So the edge of the seat is going to compress those arteries and veins if the feet are dangling. So when we have a patient in a wheelchair and we know the wheelchair is a little bit higher, we do not want their feet to dangle because that ends up compressing those areas behind the knee. Go ahead and advance. And we end up with swelling because the blood and the fluid cannot return back up to the heart because we've squished those veins. The other risk here is even worse. So swelling is bad. The other risk is even worse. Go ahead and advance. This. Inside your veins, because that blood has to go up away, it's fighting gravity. So inside your veins, you've got these little compartments with these little valves. So when the heart beats, blood goes from this compartment up to this one, the valves close. Well, when we squish those valves and keep the blood from going through, all of those cells congregate together. When blood slows down or stops, it clots. We have slowed down and stopped this blood. So what is the risk here? Blood clots. So when we have a patient in a wheelchair, we have to understand the seat is higher on purpose. We do not want the feet to dangle, which compresses the backs of the knees and puts the patient at risk for swelling and blood clots. So the way that we get around that is to use the foot pedals. Go ahead and advance. If you put the feet on the foot pedals, it relieves the pressure against the backs of the knees, allows that blood to circulate a little more effectively. We still have dependency. What that means is the feet are still low and the knee is still bent, so that blood has to make a 90-degree angle. And then when it gets to the hips, it's got to make another 90-degree turn. So when we have a patient that's sitting a lot, it's good to get them upright occasionally or laying flat occasionally to help that blood be able to return back to the upper torso. Sitting in one position for too long is not good for your patient. So this is a problem, because if your patient can't move on their own and we get them up out of bed at 5 o'clock in the morning and put them in a wheelchair, and we don't take them out of that wheelchair until 10 o'clock at night, that can be a problem. Make sense? So if our patient, we're going to learn this today, is incontinent and we're not taking them to the toilet, we need to change them every 2 hours around the clock. One of the reasons is to keep them clean and dry. The other reason is for circulation. We're moving them. If they are continent, can hold on to their own body fluids, we need to get them out of the chair and on the toilet. But either way, we're not just parking them in a chair and leaving them there for hours and hours and hours and hours. Good? Make sense? Go ahead and advance. Thank you. So we've got two different components to this. We have the foot pedals that we talked about. Those are the plastic trays that the feet stay on, that we put the feet on. But we have these things called leg rests that connect the foot pedals to the wheelchair. So this is the leg rest. This is the foot pedal. In order to get somebody into this wheelchair, I need to remove all obstacles. That means that the foot pedals have to be folded up and these leg rests have to be moved out of the way. I have to move all obstacles. So right back here, this is the leg rest. Right back here is a little catch. If I pull on the catch on the inside, it swings the leg rests out of the way. Once I get the patient into the wheelchair, we've got to get their feet on those foot pedals. So I'm going to slide these into place and they actually click. Listen. And then fold those foot pedals down. The catch is right here. See right here? That catch. Okay.
So before you put the patient, you make sure you open it so it's
Right. I'm going to show you that in 1 second here. Next slide, actually. So we have leg rests that connect the foot pedals to the wheelchair, and we have foot pedals. Both of those have to be out of the way when we're putting a patient into a wheelchair or taking them out. Go ahead and advance. This is, you might have a question on the state exam like this. You guys see it? When the wheelchair is in use, there's somebody sitting in the wheelchair. Those leg rests are in the forward position, just like that, and the foot pedals are down supporting the feet. This is how the wheelchair should look when it's being used by a patient. This is how the wheelchair should look when we're storing it. So if I don't have that leg rest snapped, locked in place, if I have it loose like this, when I go to store this and I'm moving it around, do you see what can happen? It can move around and it can injure somebody. So when we're storing a wheelchair, those leg rests have to be locked in position so they don't move around and hurt somebody. Okay? But when we're going to transfer a patient into or out of the wheelchair, it's got to look like this. The leg rests are out of the way and the foot pedals are folded up. Good? Okay. This was a lawsuit in Georgia, and this was so sad. I feel so bad for this lady, actually both of them. There was an older woman who was in having some tests done, like x-rays or something done, outpatient procedure. Her daughter had brought her in, and she had an injury. I believe it was on her leg. So she's sitting in a wheelchair waiting to go out to the car. She was done with her tests, waiting to go out to the car. And of course, we have to have a staff member take her out to the car. Well, the transport people were slow and they just weren't there. And the daughter had gone and got the car and pulled it up to the front door. So we've got a daughter waiting in a car at the front door, no transporter. There was a clerical person, registration person, who saw what was happening and said, "Oh, I'll help." Got up, took the patients in the wheelchair outside to the car. She had not been trained on how to use a wheelchair. The registration person. Wasn't her job. She was doing a good deed, she thought. But she hadn't been trained on how to use a wheelchair. So when she helped the patient out of the wheelchair to go into the car, she did not move the leg rests. And the patient tripped and ended up falling between the wheelchair, the curb, and the car, and she broke her leg. And it resulted in a lawsuit. Should that registration clerk have helped the patient? And it seems like something so, and I feel so bad for this registration clerk. I really do, because she was just trying to do a good job. She was trying to help. And I feel so bad for her. But at the end of the day, even something as simple as a wheelchair, which we all think we know how to use, if you haven't been trained, you cannot use it because there's always something you don't know. And you don't know what you don't know. And that's what puts the patient at risk.
But my question is, why wasn't the CNA helping on this?
Well, in that case, there was no CNA. They were waiting on a transporter. That transporter, their whole job is to take people around the facility. So that patient was not an inpatient. They were there for testing. So there was no CNA. Okay. It's like, when you go to get an x-ray done somewhere, right? So they were just there for an x-ray. Unfortunately, she had to be admitted because now she's got a broken leg. So I really feel bad. I mean, everybody in this situation lost. Everybody lost. And I feel really bad about it, but it gives us a great learning opportunity that even though we think the task might be very simple to do and we want to help, remember there's always something about that task you don't know if you haven't been trained. And that's what's going to put your patient at risk. Good? Make sense? That's so sad. Go ahead. All right. So when we are preparing a wheelchair for a patient to be transferred into it, you want to make sure the foot pedals are up like this, and the leg rests are out, and the wheelchair is locked. All three of those have to be satisfied. Foot pedals up, leg rests out, wheelchair locked. So wheelchairs are as easy as 1, 2, 3. Remember, there's always 3 steps that have to be done. Go ahead. All right. So once we have the wheelchair prepared, in this case, our foot pedals are up, our leg rests are out, and our wheelchair is locked. Oh, so how would the lady have gotten out? They should have waited for transport. They should have waited. Yep. It's that simple. And yeah, the daughter's probably, aggravated because she's sitting in the car blocking the front entrance. She just wants to go. And I get it, but they should have waited for transport. Yep. All right. So once we have the wheelchair ready, then we'll be able to transfer the patient into it. Make sense? But before we can do all of that, this patient is laying in bed, just like this lady, laying in bed. if I've got the wheelchair like this and locked, I can't get to her because it's in the way. So before we do any of that, I'm going to have the leg rests and the foot pedals out just like this. I'm going to get the wheelchair close, but I'm actually not going to lock it yet because I need to get this lady sitting on the side of the bed, and I don't want that wheelchair too close because then her feet will hit it. I want the wheelchair close enough that after she's sitting on the edge of the bed, I can grab it, though. I don't have to leave her. So I don't want the wheelchair way over here where I have to leave the patient. I want it close enough to grab, but not so close that her feet are going to get tangled up in it. Good. So we get the patient sitting on the side of the bed. We get the wheelchair. We get the gait belt around the waist. We get the shoes on. We bring the wheelchair close, lock it into place. It's got to be almost touching the patient. Lock it into place, and then we can transfer the patient. We're going to count to 3. 1, 2, 3. Lift the patient up. Turn them. When they say sit, we'll sit them down in the wheelchair. And then we're going to take the gait belt off, turn the wheelchair around, make sure their feet are on the foot pedals, lock the wheelchair, and end our skill. It's not a hard skill. They give you 11 minutes to do this. You don't need 11 minutes. It's not a hard skill, but there's so many little pieces here about the wheelchair that you have to learn. Good? Good. All right, pivoting a patient onto the side of the bed is not nearly as hard as you think it is. We're going to get the patient to scoot toward us. That is my son. He is 6 foot tall. I am not. I can easily pivot him to the side of the bed. I am not especially strong. I'm getting old. You can pivot somebody a whole lot easier than you think you can, but you got to know how to do it the right way. When you want to get somebody to sit on the side of the bed, you're going to get them to scoot towards you, put this arm under the shoulders. This arm goes over the knees, not under. This is the mistake that people make. I'm not going to lift this person up and carry them. It's over. When I do this, and let me show you on her, because she cannot help. She is a mannequin. Now, she also can't sit, so keep that in mind, okay? All right. So I'm going to scoot the patient toward me. I'm going to put my arm underneath her shoulders and over her knees. Remember, it's over. I want to bend at the knees, not the waist. I want my leg muscles to do the job, not my back. And I'm going to lean against the bed for leverage. So I'm going to place my arm underneath her back, and I want to grab that furthest shoulder over the knees. And on the count of 3, 1, 2, 3, you pivot. Now, she can't help. And she's a little heavier than you would think. Good? Makes sense? But you're going to be doing this on a real person. You're going to do this on a real person. But they are going to try to find somebody smaller than you to do it on. Okay. Oops. Good? You would just let the nurse know. If it's a patient that you have concerns about, I want you to try this before you get to the exam. Whether you try it here or at home, I don't care. But you need to try this because I guarantee you, you have more capability on this than you think you do. Okay? Yeah, they shouldn't, but yeah.
So in a clinical setting, say from the camp that you're going to put this patient on a wheelchair because they're going to physical therapy.
Mm-hmm.
One question is, if the patients he can do by himself, before you ask us, is it okay if you ask her to see it out?
So okay. I'm going to address this in 2 different ways. Okay. When you go to work at the beginning of your shift, you are going to get a shift report. So the person that's going off of shift is going to tell you about your patients, what to do with each one, what their level of ability is. So it's kind of like passing on the care plan. Okay. Now, anytime we have a patient that needs assistance in mobility, whether it's getting out of bed into a wheelchair, walking, whatever, we default to assistance of one, right? So you will be able to help that person or should be able to help that person. But there are some situations where you will see times two or assist of two. That means we need two caregivers for that particular patient. I'm going to tell you in 99% of the cases, 99% of the time, the second person's going to get in your way. Because there's not a lot of room here, right? How do we get two people to work together to move one person? They get in the way. Does that make sense? So assist of two isn't all that efficient or effective. And then you got to go find somebody and they're busy doing their stuff and it becomes a problem. So we have other ways of managing this now. We have Hoyer lifts or mechanical lifts. And that means that we're going to turn the patient on their side, put a sling under them, just like we did with the sheet. Put a sling under them. We attach the sling to a big hoist. It's kind of like an engine hoist. We attach the sling to it, and then we press a button, and the sling pulls the patient up to a sitting position, and we bring them over and just place them in the chair. So a mechanical lift does much better than a second caregiver. But the problem is with a mechanical lift, we need a second caregiver because your whole focus is right here on the control pad. If your focus is here, who's paying attention to the patient? So we need a second caregiver to have eyes on the patient to make sure that they don't fall. Make sense? Now we have another type of lift called a sit to stand or Sarah lift. And this is kind of a contraption, I guess. It's kind of like a triangle that you bring over to the patient. They hold onto the handles, and it either has a seat that goes under them or a strap that goes around them that helps lift their middle body. Now, a lot of places are going to mechanical lifts because they don't want you guys to blow out your backs. So mechanical lifts are going to be very, very useful in clinical settings. But how do we know when to use them? The care plan. So instead of having assist of two, in most settings, you're going to have a lift used instead. Great question. Any other questions? But you do need to try this in a controlled setting before you get to the test, because you need to have a certain level of confidence that you can turn somebody, you can lift somebody, you can transfer somebody, even somebody larger than you. Okay, does that make sense? You can. You have the capability, you just don't have the confidence yet. The only way that you get the confidence is to try it out on your own. Good? So the two secrets to pivoting a patient onto the side of the bed is the arm under the shoulders has to go all the way under the shoulder. You got to get up close and personal with this patient. All the way. You want to hold that furthest shoulder in your hand. If you just have your hand a little bit, you're never going to be able to turn them. We need leverage. This arm goes over the knees. Now, if I were on that side of the bed, it would be opposite. This hand would go under the shoulders and this one over the knees. Good. Questions? Questions? I'm going to show you the video on this one. It shows this pivot really well from a couple of different angles so you can see it. Once we have the patient pivoted on the side of the bed, go ahead and advance for me, please. Then we're going to put their shoes on. Go ahead and advance. And then we're going to put the gait belt on. Doesn't matter which one you do. I don't care whether you put the gait belt on first or the shoes on first. Nobody cares. But you do want to make sure their feet are flat on the floor before you stand them up. You want their hands on your shoulders, and you're going to hold the back of that gait belt. And you're going to count to 3. Go ahead and advance. We want to make sure that wheelchair is at an angle and the wheelchairs or the brakes are locked. Go ahead. It has me putting the gait belt on here. Again, it does not matter when you put the gait belt on. Nobody cares when that gait belt goes on. Go ahead. We're going to use that oblique angle, 1 foot in front of their feet. Go ahead. And then you're going to have them put their hands on your shoulders, and on the count of 3, you're going to lift. Go ahead. You're going to swing them around. When they say sit, you're going to help them sit in that wheelchair. Go ahead. Once you get them in the wheelchair, go ahead. Then we can get the feet on the foot pedals. Go ahead. Remove the gait belt, lock the wheelchair. Go ahead. And it does not matter what order you do those 3. Don't leave the gait belt on the patient. Has to be removed. Don't leave the legs dangling. Swelling and blood clots. Good. Go ahead. Okay. And we'll make sure the patient is positioned properly in the wheelchair. Make sure their hips are against the back seat. Just make sure that they look right. For the test, they will, because you're working with able-bodied people. But in a clinical setting, you may have to adjust your patient a little bit. Go ahead. And then we'll do the closing. Easy. Good. Any questions? All right. In here, I'm trying to get through the instruction here because you will have some practice time today. And I want you guys to be able to practice with the wheelchair because most of you don't have one of these at home. Okay. All right, Jake, go ahead and do our video. I'll get the light and the screen.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay, and I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders, maintain a wide stance, and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay, can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient, and we'll lock it into place. Okay, Mr. Jones, can you bring your feet together and slightly back? Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gate belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock your wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Yep, lights on. Okay, we just got another comment that didn't come through on this stream. It's just on my YouTube channel, but I did want to give a shout out because it just came through. This is, let me see here. Sheree94 says, Miss Patty, I had to come back and let you know that I passed my skills test because of your videos. As of 3/29/25, the world gained another CNA. This is the first step in my nursing career to become a labor and delivery RN. Thank you for all the work you do. So congratulations, Sheree. Congratulations. Super proud. All right, we're going to go ahead and take our break. When you get back from break, we have 2 more skills to do. Looks like we're good. Oops. All right. Any questions on wheelchair transferring? To me, that's probably one of the easier skills. Washing skills to me are probably the most demanding because there's so many steps to it and so much that you have to do. The mobility skills like range of motion, sideline position, ambulate, and transfer, those are the mobility skills, bless you. And you will get a mobility skill on the exam. To me, those seem a little easier. You may, have a different opinion, but I will tell you, universally, I don't know how this happens, but the skill that you dread is the one that you get. I don't know how it happens, but it does. So if you dread partial bed bath, if you're like, oh my gosh, I really don't want partial bed bath, that's the one you're going to get. Don't ask me. I don't know how the cosmos works, but I have heard from thousands of people that have said that. So I would start dreading range of motion. All right. So we're going to learn how to feed a resident in a chair. That's what we're going to, the next skill that we're going to do. And then we're going to get into Peri-care. Peri-care is a washing skill. We're going to use that same leaves method that we used with partial bed bath. There's not a whole lot to teach you with Peri-care, but I do have to talk to you about incontinence. This, however, feeding, you would think is a pretty easy skill. I have a lot to tell you about this. This requires a lot of lecture, unfortunately. The skill itself, not hard. You're feeding somebody a couple bites. It's really not hard. We know all the principles involved. There's nothing new to learn here other than feeding itself. This is going to be done on another live testing student. So one of you guys may be fed during the test. It is a single serve pudding or applesauce cup. And I know, probably not your favorite. If you're allergic, please let the evaluators know. If you just don't like, try to choke down a couple of bites. You're only asked to take 4 bites. That's it. And the spoon is going to be half full. So you're talking about 4 half spoonfuls of something that you may not particularly like. Now, if it's going to make you throw up, please tell the evaluator. Some people have texture. I have texture issues. Not with that. I can eat pudding. I can eat applesauce, but I have texture issues in other areas. So if that's you, please let them know. But if you can choke down a couple of spoonfuls, please do so. Because here's the thing. Remember when you get checked in, they have to divide you up into groups. So remember that you had slip-on shoes. So you would be she's got transfer. So you would be a good candidate for her. But if you tell me that, hey, I'm allergic to milk, so no pudding, and I'll throw up if you try to give me applesauce. Now you can't be a patient for feeding. So now I got to try to figure out somebody else to put you with that can be a patient for both feeding and transfer. And that just really complicates my life. And I want to be at home in my pool drinking my margaritas, not trying to figure this out. So use that sparingly. Make sense? But if you've got an issue, please let them know. And I'll give you an example of this. We had a student many years ago who had an amputation. She had a prosthetic leg. I didn't know. When she was attending class, everybody was in scrubs. And she, had had the prosthetic for a very long time. She had accommodated very well. She didn't have any changes in her gait. I mean, I did not know until she told me about halfway through class. No idea. I did not think to tell her, you need to tell the evaluators. It just didn't dawn on me. So during the test, she gets paired up with somebody who has to demonstrate range of motion, hip, knee, and ankle. And she didn't say anything. She just goes, and they told her to lay in bed. She went and laid in bed. Well, the person that was testing, the one being graded, goes to lift the leg, and you expect a certain amount of weight to a leg. So she goes to lift the leg, and as she did, the whole prosthetic came off. And she dropped the leg. It goes clattering to the floor. She starts crying immediately. And the evaluator was just so dumbfounded, did not know what to say at that point. It was just mass chaos. That's not fair to the person testing. Although I'm sure it was quite comical at the time. What's that? Yeah, yeah. So she probably should have, kind of spoke up and said, hey, I may not be the right person for this. But she didn't. So I use that as an example to tell you why, if you have something, you do need to speak up, because we don't want to derail somebody who is testing. That's not fair. Does that make sense? Another one that happened is somebody that had just had a couple of extractions. I think they were, I don't know if they were wisdom teeth or not, but they were molar extractions. And they were the patient for mouth care. So when the person was doing mouth care, they never spoke up, never said anything. When the person was doing mouth care, they ended up bleeding. And the person being tested freaked out, because if you're just brushing teeth, there shouldn't be a whole lot of blood, and the girl is rinsing and spitting, and there's lots of blood coming out. And if you got something, please say something. Okay, good.
So should I tell them that I wear a hearing aid then?
Yeah, yes, I would definitely mention that. Yes.
So, what if that happens to you? Do you fail?
No, but try to keep your cool. I mean, I know it's hard because you're testing and your anxiety is like way up there, right? Because you're testing. And I get it. I do understand. But try to keep your cool as much as possible. Just step back and say, evaluator, this is not according to the care plan. And that will kind of perk them up. And what do you mean? What's going on? Try to keep your cool. Try to keep your cool. I don't know if I could have kept my cool with a leg falling off. I don't know. That one would have, I'm a pretty cool person, but that one would have probably challenged me as well. Do the best you can. All right, so let's talk about feeding. This is a live person skill. You will have a live person to feed, but they're only going to eat 4 bites, and then they're going to say, I'm done, or I don't want any more, or whatever. You are required to use 2 forms of encouragement. So you can't just say, oh, thank God, you're done, I'm out. We really want to encourage people to eat. I'm going to get into this a little bit more in a minute, but you're going to use 2 forms of encouragement. You've got 9 minutes to do this. We're feeding somebody 4 half spoonfuls, and they're giving us 9 minutes. So this isn't it's not a hard skill. It's not a hard skill. It's hard to be a patient for. It's hard to be a patient for. Go to page 109, and we're going to look at the care plan at the top of the page. It tells us to feed a resident a snack who is unable to feed him or herself. It does not say they're paralyzed. It does not say they cannot move. It just says they're unable to feed themselves. Don't put words into the care plan that don't belong there. So one of the things that we're going to do is give the patient a hand wipe before we feed them. That way, if food starts to fall and they bring their hands up to their face, their hands are clean. Giving them a hand wipe also is part of eating ritual. Most people wash their hands before they eat, so it can help stimulate the appetite as well. But don't add words to the care plan. It tells us the patient is in an inappropriate position for eating. I want you to underline that, because I do not care what your eyes tell you. The care plan says they're in an inappropriate position for eating. So if I asked you guys to slump or slouch, you might do what you're doing, right? Just this. That might be your definition of slumping or slouching. Have you ever met a 12-year-old? They all eat like this. This, in your mind, may not be an inappropriate position for eating, but what does our care plan say? Inappropriate. So for the test, we have to ask the patient, can you please sit up straight? Doesn't matter what your eyes tell you. I don't care what you see. You're going to ask that patient to sit up straight. You don't have to physically like manhandle them and get them sitting. You just ask them. Okay, good. It also tells us to document the intake on a food and fluid intake form. You can see an example of that in the second column. If you keep your finger there and go to page 169, you will see a larger version of that documentation sheet. So eating, I do this one toward the end of the program because it does not follow our normal rules. So I spend 3 weeks teaching you all these rules, and then I tell you, yeah, don't pay attention to those for this skill. Eating is different than everything else we do. And there's a couple of reasons for this. First of all, we're not going to close the privacy curtain for feeding. That's because eating is a social event. We gather in groups to eat. We have conversations when we eat. People that eat in isolation do not eat well. Think of all of the milestones in your life. They all revolve around food. Weddings, food. Funerals, food. Birthdays, food. Graduations, food. Baby showers, food. I mean, food is a part of our social fabric. So when you isolate a patient, they tend to not eat very well. We don't pull the privacy curtain for this one. This is a skill where we don't use a barrier on the table because our food tray is our barrier. We don't need a Chuck's food tray. We'll do that. At the beginning of the skill, you will have a food tray already on your overbed table that will have a cup of water, a single serve food item, a spoon, a fork, and a napkin, all on a tray. They want to make sure that you're using the spoon, not the fork, to feed somebody pudding or applesauce. Kind of makes sense, right? So the tray is already prepared. Just like in a clinical setting, you don't go make the trays. Dietary makes the trays and delivers them. So you would take the tray to the patient, but in this case, the tray is already there. Good? It is the only skill that you are required to have a conversation. And every other skill, we tell the patient what we're doing. Okay, I'm going to lift your arm above your head like you're asking a question and bring it down to the bed. I'm going to take your vital signs. I'm going to wash your face. We're telling them our steps. We're telling them what we do. We don't do that with this. Do you know how awkward it would be? I'm going to put the spoon in the pudding, and now I'm bringing the spoon and the pudding to your mouth. I mean, that treats somebody like they're like 9 months old. Yeah, exactly. Exactly. We don't do that. We want to have a conversation. Now, it doesn't need to be a real conversation. You can make something up for the test. Make something up. They're showing a movie on the big screen in the activity room later. Do you want to go? The bingo jackpot's up to $2.10, and Martha thinks she's going to win it. What do you think? Did you see those little kids come in all dressed up in Easter costumes. Weren't they adorable for the Easter egg hunt? I don't care what you talk about. They don't either. But the fact is, you need to talk. But I'm going to tell you, in a clinical setting, you have to get comfortable talking to strangers. And it's not always easy, especially for young people. You haven't really developed that skill yet in most cases. And a lot of young people aren't really comfortable talking to people they don't know. So you have to come up with conversation starters. I have one that I use routinely. I ask patients, what's the most exciting place you've ever been? It's a great conversation starter because most people have been more than one place. So it gives them kind of a catalog of things to talk about. I can ask people, where did you grow up? Can you tell me a little bit about your life? What was life like? How is life different now than it was when you were growing up? People like to talk about their life experiences. If people have photos on the wall, you can talk about the photos. People don't put their deepest, darkest secrets on the wall. If it's displayed, it's something they're willing to talk about. Like in my old setting, I had a picture of my husband and I on a cruise. I'm willing to talk about that. I am a big cruiser. I've been on over 30 cruises. I love to cruise. So I'll talk to you about cruising all day long. And I've got a picture out to let you know that, hey, that's a good topic for us. Make sense? Look around your patient's environment. But you have to have a conversation. Now, sometimes your patients will surprise you. One of the most interesting conversations I've ever had with a patient. This was back in probably the early 90s. I went up in Citrus County, which is where I grew up, is in Citrus County, one county north. I went to an assisted living facility to do a very extensive wound care on a patient's leg. And this is like a 45-minute process to take the old dressing off, clean the wound, put the new one on, and there's a compression bandage that had to be applied. So this is a long process. So I pull over my little rolling stool and I sit down, and I hadn't ever worked with her before. And so I pulled out my tried and true question. Now, this woman, she was in assisted living, but her own apartment, more on the independent side. And she was in her late 90s, had all of her faculties. So I asked her, so Miss Mabel, where's the most exciting place you've ever been? Now, this was her answer. Oh, honey, I've never been anywhere. Now, remember, this is Citrus County, okay? I said, what do you mean you've never been anywhere? This is Citrus County. I mean, you had to have gone somewhere, right? Where'd you go for your honeymoon? And she said, oh, we went to my aunt's cabin out in Floral City. I said, okay, do you mean you really haven't ever been anywhere? You never left Citrus County? And she says, no, actually, it's not entirely true. I was Brooksville, but I don't remember that. You've never stepped foot out of Citrus County in 90-something years. You've never been to Ocala? She says, oh, no. Oh, my goodness. This is living history sitting right in front of me. Do you know how many changes she has seen in little Citrus County in 90-something years? She remembers when the roads were paved. She remembers when the courthouse was moved. There were two families in Inverness that were rivals, and the son from one family was supposed to marry the daughter from another family and kind of get them more aligned, and the daughter ran off with some other boy, and that caused a big brouhaha among all the families. It's crazy to hear the stories. And what was interesting to me about that whole situation, I learned a whole lot. And I called the office and I said, hey, send me back here, because this is living history. I can't get this information out of a textbook somewhere. This is where I live. So I was very, very interested. But what struck me is the most interesting conversation I've ever had with a patient was with someone who didn't think she had anything to offer. All she needed was somebody to show some interest. Be that somebody. Talk to your patients. And when you're feeding them, that's the best time to talk to a patient. Catherine says, do we allow them to swallow before we start the conversation, or do we start the conversation before we start feeding? That's a great question, Catherine. And I'm going to put this in terms you can probably understand, right? Have you ever gone out to eat? Has anybody ever gone out to eat? Okay, so when you walk into a restaurant, we all know you're not supposed to talk with your mouth full, right? So when you walk into the restaurant, it must be dead silent all the time, right?
No. It's pretty chatty.
Okay, so if we go out to eat and it's pretty loud and chatty and we're not talking with our mouths full, how does that happen? Okay, so we talk when somebody else is chewing, and then they talk when we're chewing, and we do this naturally without even thinking about it. You don't walk into a restaurant and it's dead silent, because that would be seriously weird. Very awkward. Does that make sense? Good. I hope that helps you, Catherine. So we're going to sit. We're going to have a conversation. We're not going to use a barrier, and we're not going to pull the curtain. These are the ways that this skill is different. And you have to sit when you're feeding somebody. You cannot stand over somebody and put food into their mouth. There's a power dynamic there. The patient will feel rushed, but they will also feel inferior. And let me explain what I mean by that. This eating, being fed, is the hardest skill to be a patient for. Patients do better with Peri-care when you're up in their most personal space. They do better with Peri-care than they do with being fed. Isn't that crazy? So let's look at the psychology here. Eating is the very first skill you become independent at. The very first one. You learn how to hold your bottle before you know what hunger is. You pick up peaches and Cheerios off a high chair tray and get them to your mouth before you can fully sit up on your own. Eating is a first skill you become independent in. So when you lose the ability to feed yourself, it affects you psychologically like no other skill can. You also know that if somebody doesn't feed you, you will die. Maybe not today, but somebody else that you have no control over has the power of life and death over you. And this happens. There have been many cases of CNAs that put a food tray in front of a patient that needs to be fed, decides they don't want to feed the patient, leaves the food tray there, and then documents the patient refused. Now, I want you to think about that from the patient's point of view. They can see the food, they can smell the food, and they can't eat it. That is torture. That is horrible. And we should never, ever engage in anything like that. But it does happen. So you should be watching for this. If a patient cannot feed themselves, it will affect them psychologically. So being open, having a conversation, encouraging them to eat, sitting at eye level, normalizing this interaction so it doesn't feel like they're being fed. It feels more like they're eating with company is a big part of this skill. Do you guys see that? So we have to sit. We want to make sure the patient is upright, so we're simply going to say, hey, can you sit up straight? Our care plan said they're not, so we're going to ask them to sit up straight. We're going to offer a clothing protector and a hand wipe. Now, they may not want the clothing protector. That's okay. We can offer it. Me, I need one. I wear everything. everything I eat ends up on me. I have no coordination. I'm really bad at that. But my grandmother, if you tried to put a bib on her, would absolutely tell you in no uncertain terms, I am not a child and I do not need a bib. So we don't call them bibs, we call them clothing protectors, and we do offer the patient. They can say no if they want. The evaluators will give you instructions, but as far as I remember, it's your preference. You can choose to or not. And I think that's because the towel that they would use as a clothing protector has lint on it. And if you're wearing dark clothing, you may not want that lint. However, you are being fed by somebody else, and that somebody else might drop food on you by accident if they're not very, remember, they're being tested. They're nervous. What do you think hands do? Oh, man. They might drop stuff on you. So I would take the clothing protector just to be sure. But I think they leave that up to you. We're also going to offer a hand wipe. Again, this kind of goes toward ritual, but we also want their hands clean. We're going to sit facing the patient while we feed them. We're going to offer a drink before and every 2 to 3 bites. So this is why they have you take 4 bites as the patient, because they want to make sure that whoever's feeding you is going to offer that drink at some point in there. So everybody has different food preferences, and you probably haven't stopped to think about this, but how many of you guys don't like your foods to touch on your plate? Do I have anybody in here? Okay. How many of you guys eat all of one thing on your plate before you move to the next thing? Okay. Some of you take a little bit of this and eat it, and then a little bit of that and eat it, and that you just kind of graze around your plate. And for others, it's like, no, we don't do that. How many of you like your corn and mashed potatoes mixed? How many of you are like, absolutely not? Okay, some people like to eat their salad first. Other people like to eat their salad last to help with digestion. Some people eat dessert first because life is short. Everybody has different eating preferences. So we're feeding the patient. We kind of need to be familiar with their feeding preferences. But this also goes with liquids. Some people drink before a meal. My aunt was like that. She had done some modeling when she was younger, and she was taught back then that you drank an entire glass of water before you ate, and that helped fill you up and it reduced the amount of food that you ate. So she kept that habit up throughout her entire life. She always drank an entire glass of water before she ate. And doesn't work for me. I've tried, doesn't work for me. I don't produce a lot of saliva, so I have to drink during my meal. I'll drink before, and then I take a bite and I take a drink. And, I'm drinking all throughout my meal. Now, my husband, he does not drink with his meals. He drinks after his meals. Everybody is a little different. So we're going to offer a drink before. We're going to offer a drink every 2 to 3 bites, and then we can offer a drink at the end as well. But that's why you're only taking 4 bites, because somewhere in there, they should be offering you a drink. Okay? We'll feed slowly. The spoon should only be half full. Small bites. Make sure they chew and swallow, or nothing really there to chew, but make sure they swallow before you offer the next one. In a clinical setting, when you've got an entire plate of food, you want to ask them, what do you want first? What do you want next? And we're just their hands. We're going to let them direct to the extent they can.
Do we get to pick between putting that?
Sometimes it depends on what the testing center has available. Most of the time they have both, but sometimes they may run out of one or the other, or they haven't gone to the store or whatever. What I suggest to students that have particular issues with this is, if you don't feel comfortable saying, I'm not your patient for that, I'm just not real good at being a patient for that, you can take I like butterscotch pudding, but I'm not a real big fan of vanilla. Well, I know I'm at the testing center all day, so I have no problem packing a peanut butter and jelly sandwich and a thing of butterscotch pudding because I can take that into the testing center with me as a lunch. And then if I get picked as a patient, I can say, I've got my own pudding. And the evaluators will say, cool. Okay, good. Spoon should only be half full. I'll tell you a story about this. When we were at testing center, the person that was feeding the patient was super nervous. I mean, she had been out in the parking lot throwing up before testing. I mean, she was like serious anxiety. And I understand that. My daughter, by the way, took this class and she went and got her certification years and years ago, but she also has very severe anxiety. And she was like, I don't know if I can do this. She woke up the morning with a migraine. She was throwing up and I made her go test. And it's because there will never be a better time. And once she got done with the test, she's like, it wasn't as bad as I thought it was. And she, was certified. So I get anxiety. I do. I absolutely do. But we still have to be able to function as CNAs. This person who was demonstrating this skill for testing was being graded. She took that spoon and she got a huge spoonful, put it in the person's mouth, and it went this fast. She wanted it over, but the person being fed is literally a chipmunk. And the pudding is sliding down their face, and it became a choking hazard. So the evaluator had to stop the skill because it was a choking hazard. So I know nerves can get to you. I get it. I really do. But remember that during the test, if you can't get yourself under control and you're putting the other person at risk, you're not going to perform well. I get a million comments on my YouTube channel, million comments. One of the most common comments that I get is, I'm going to be nervous for the test. I hope I pass. I don't like to be watched. And that is really what it boils down to. I need you guys to understand that nobody wakes up on testing morning going, woohoo, somebody's going to watch me do my stuff, right? Nobody likes to be watched. I do this for a living. I am on camera right now. I create videos that show you I am the face of CNA skills. But if I had to go in and test and I was being judged, I know it would affect my performance. I get it. I need you to understand that. I get it. However, the one thing that I want you to remember is that testing day is the first time you're going to be watched, not the last. Because if you think those evaluators are judging you harshly, wait until the families get involved. You will be watched in everything you do. You will be watched by the patient that you are doing things on. You will be watched by the families that are entrusting their family member to your care. And you will be watched by the nurses who are assuming liability for what you are doing. Testing day is the first day you are being watched, not the last. And once you start to understand that, it helps with your anxiety. Does that make sense? That's why I always wait until third week to explain that to you, because you've got enough under your belt now that you should be able to kind of be able to take that in. Good? Good? All right. We're going to have a conversation. Again, the conversation doesn't need to be real for the test. Doesn't need to be real for the test. You can just say something like, they're showing a movie. Do you want to go see it? But you have to do something. We're going to encourage intake. Now, there's 2 different ways that you need to do this. I'm going to give you 3. You can pick. The first is I'm going to be very sweet, and I'm going to ask the patient, are you sure you don't want just one more bite for me, please? That way the patient doesn't feel like I'm rushing and just trying to get out of there. The second thing I'm going to do is offer something else. We've all had these days. Every one of us has made something or gotten something, taken a bite and gone, nope, not it. Not what I was looking for. Yes. Okay. Helen says, good morning, Miss Patty. My question today is, you are feeding your resident when the nurse brings in the patient's medications and asks you to give her with her food. What is your response? Okay, go ahead and take that down. Helen, I'm going to answer that in 1 second. Let me get through this and then I'll address that. That's a great question. Okay, so are you sure you don't want just one more bite? Can I get you something else? The third thing that I do is tell me if you get hungry later and we have snacks available. So I reassure them that food is available because maybe they're just not feeling quite right now. And I want them to have the freedom to ask me for food when they get hungry. You need to use 2 of those. Are you sure you don't want just one more bite? Can I get you something else? Let me know if you get hungry later. Okay. Need to use 2. That lets the patient feel cared about. So let me answer this. So you're feeding a patient, the nurse walks in with a cup of pills, doesn't want to interrupt your feeding, sets the pills down, says, can you just make sure that she takes these? The answer to that is no. You have not been trained. Remember, we have to be trained to do a task. And even something as simple as taking somebody out to a car in a wheelchair without training can put them at risk. You have not been trained to observe medication administration. Now, this changes if you are a med tech. If you've taken the training for medication, now you're trained. But let me explain to you why it's still not a good idea. Still not a good idea. Because when we give medications, we have to document that that medication was taken. We can't document something we didn't do. Right. So I can't document that the medications were given if I didn't see the medications taken, because I can't document something I didn't do. That's a nursing principle. Do you see how that's a problem? If I leave the cup of pills with the CNA, I can't document that those pills were taken. Good. You never, ever, ever want to document that a patient took pills when you aren't 100% sure that the patient took the pills because of something called diversion, drug diversion. One of the biggest risks in a facility right now is staff members taking the patient's medications. It happens. There was just a case not too long ago, a couple months ago. This is horrible. Patients after surgery were not receiving pain medication. They were receiving water in their IVs. Can you imagine having surgery, asking for pain medication, and getting water, sterile water? Do you know where that medication was going? Into the nurses. That is correct. Yep. We can't trust medical people. You can't trust medical people. If somebody gives you a cup of pills and says, can you make sure the patient took these? Your answer is no. You did not dispense them. You have no idea what's in that cup or what should be in that cup. Because that nurse, what's going to happen is that nurse is going to give you some pills to give to the patient. That nurse has already taken out the good stuff. She gives you the cup of pills. You give it to the patient. The patient complains, and the nurse says, well, I gave them to her. She must have taken them. You see how that puts you in a very uncomfortable position, trying to prove a negative? You're trying to prove you did not do something. How do you prove you did not do something? Yeah, don't do the task. Yep. Your answer is, no, I'm sorry, I can't do that, but I'd be happy to bring the patient to you once she's done eating. Absolutely. Okay, good. You have to protect yourself as well as the patients in some cases. All right, so we're going to encourage the patient. We're going to leave the area around the mouth clean, just like with mouth care. And then we'll do our closing. Now, a question I get asked a lot about this scale is, I did not see gloves on there. Do we wear gloves when feeding? The answer is if the care plan tells you to. If the patient has a contact precaution and the care plan tells you to, that's fine. Other than that, do not wear gloves. First of all, you're on the other end of a spoon. You're nowhere near their body fluids. The second reason is gloves give off an odor, particularly latex gloves, and that smell is an appetite suppressant. Do not go around sniffing latex gloves to kill your appetite. It is effective, but you don't want to breathe in latex. When you put gloves on, that spoon hand is right under their nose. Smell and taste are tied together. So you don't want to wear gloves when feeding a patient because it will kill their appetite unless the care plan instructs you to. Good? Good. Now let's talk about documentation. This is the form that you will use to document. This is the form. It's based on percentages. We've already got that. It's based on percentages. This is the percentage scale. If they eat all, it's 100%. If they eat none, it's 0%. If they eat half, it's 50%. 25 and 75 are estimates. Yeah, they ate most of it, but not all. 75. They kind of picked at it. 25. They're estimates. It's not like hard and fast scientific. It's an estimate. Is that me?
I believe so.
Nope. Okay. So if you look at this, this is an example. If you look at that plate, there's a sandwich, some Jell-O, and some broccoli. I don't know why they put those three together, but sandwich, Jell-O, and broccoli. You go to pick up the plate, and that first one is what you pick up. They took a bite out of the sandwich, ate one of the stalks of broccoli, and a couple pieces of Jell-O. That's not half. But they didn't refuse either. What would we call that? Okay, it's got to be on a percentage scale.
25%?
So 25%. If you look at the second one next to it, they ate about half of the sandwich, about half of the broccoli, about half of the Jell-O. So what would we call that?
Oh,
50. Yeah, about half. That's right. Down at the bottom, they ate most everything. It's not a clean plate. They ate most everything. What would we call that one? 75. Now, let's talk about that last one because this one gets mixed up a little bit. When we say 100%, it doesn't mean that they have a clean plate. A little bit left can still count as 100%, like a broccoli stalk. Broccoli stalks don't really count. Okay, we can call that 100%. In reality, that would be closer to 90, but we don't use 90. We use a quarter scale. That is closer to 100% than it is to 75. No, you wouldn't. You wouldn't, but it's closer to 100. Now, I want to go back an hour. How many bites did I tell you were giving?
Full.
How full is the spoon? So we are giving 4 half spoonfuls. So how much are we going to be documenting that they ate? 25%. So for the test, it'll be 25%. If you gave them any more than that, you messed up. Does that make sense? Okay. So fluid for the test is going to be based on that same quarter scale. Okay. They drank half of the cup, half. If they drank all of the cup, 100%. 25 and 75 are estimates. But in a clinical setting, we don't use that quarter scale for fluids. We use actual numbers. So for the test, we're just going to use that percentage. But in a clinical setting, we have something called intake and output. Now, intake and output, I have a whole lesson on this on page 107 for you. Intake and output is going to be measured using numbers. 107. This is based on numbers. 1 ounce equals 30 cc's. In medicine, we use the metric system. cc's, mLs, it's all the same. cc's equal mLs, it's the same, but we use the metric system. So if you look at your water bottle there, it'll tell you, if you look at the label, it'll tell you how many ounces and how many cc's were in that bottle. So can you look at that bottle and tell me? Okay, so in parentheses, mLs and cc's are the same. So it's 16.9 ounces or 500 milliliters. Anything prepackaged is going to be marked with how many milliliters. But if it's not prepackaged, if it's a coffee cup, we have to know, and we're going to find this out during orientation, that the coffee cups in this facility hold 6 ounces. So we need to know how many cc's is that. The water cups in this facility hold 8 ounces. How many cc's in that? So we always multiply the number of ounces by 30 to get cc's or milliliters. Remember, cc's and milliliters are the same. So if we have something that is 8 ounces, we would multiply 8 by 30, and that would give us 240 mLs. Good? 6 ounces, so you would multiply 6 by 30 and get 180 mLs. Good? Make sense? All right, page 106 gives us an activity that we can do. When you're looking at page 106, it asks you to estimate the percentage eaten in the first and the second column. But if you go down to the bottom of the second column, there's a fluid measurement activity. So if you look at that first cup, it's 6 ounces of juice. So if it's 6 ounces of juice, how many mLs would it be? 180. So write 180 below it. The milk carton actually tells you how many mLs there are. So how many mLs are in that milk carton? 240. And then we have 12 ounces of coffee. That's a lot of coffee. So 12 ounces, 12 times 30 is 360. So at the end of our shift, they drank 6 ounces of juice, 8 ounces of milk, and 12 ounces of coffee. That's what they drank while we were here with them on this shift. We would add those 3 together. So can anybody add together 180, 240, and 360? Close. 780. Yep. So our total intake for this shift is 780 mLs. You will get a math question on the state exam. You are either going to have to convert ounces to mLs, like it'll say 6 ounces of juice equals, or you will have to add up, just like you did here. They're going to give you several mLs that the patient took in, and you will add up the intake for that shift. Depends on your facility. It's the same thing. mLs and cc's are the same thing. Okay. For those people that are super detail oriented, I don't want to get a bunch of yelling at me in the chat. I know ounces and cc's, or I'm sorry, mLs and cc's measure differently. cc's measure volume. mLs measure fluid. But from the metric system, they are equivalent. They can be used interchangeably. So you will go by your mLs is technically more correct, but your facility will decide. We've been using CCs in medicine for 200 years. There's a big push to switch to MLs, but at this point, nobody really cares. Okay. Go to page 132 for me. And let's talk about documentation. This is a list of common medical abbreviations that are used by CNAs in most healthcare settings. Anything that is highlighted in gray is something that could potentially be on the state exam. So you really want to learn the ones that are in gray for sure. But let me demystify this for you. Most of this is abbreviated Latin, not abbreviated English. So it's not going to make any sense to you in English. Such as if you go about 3/4 of the way down, you're going to see NPO. NPO means nothing by mouth. It is not abbreviated English. It is abbreviated Latin words that mean nothing by mouth. Once you understand that, medical abbreviations become a little bit easier because you're not trying to make them make sense. Go up to the very top, you'll see PRN. Again, abbreviated Latin. That translated means as needed. And then below that, you've got BID and TID. Again, abbreviated Latin. B stands for bi. How many wheels does a bicycle have? 2. So BID means 2 times in a day. Well, if B stands for bi, what do you think T stands for? Tri, which how many wheels does a tricycle have? 3. So BID is twice a day. TID is 3 times a day. Good? Again, not abbreviated English. Q stands for every. So if you see something that says Q2H, it means every 2 hours. And then you get to QHS. Well, we know Q means every. HS is how they say bedtime. Think of it loosely translated as hour of sleep. Good? Does that kind of demystify that for you? Most medical abbreviations are abbreviated Latin, not English. Don't try to make them make sense in English. But then we've got some that are abbreviated English. So that's really going to mess us up. If you look under daily activities, we have A&O, which means alert and oriented. That is abbreviated English. You got ADLs, which we've already learned is activities of daily living. That is abbreviated English. You've got BM for bowel movement. You have BRP, which is bathroom privileges. And you have BSC, which is bedside commode. So some of these are abbreviated English and some of them are abbreviated Latin. You just have to learn them. Does that help demystify that a little for you? Good. Anything that is highlighted in gray could show up on the state exam. But I want to talk to you about that NPO thing for a second since we're on food, feeding. NPO means nothing by mouth. You may see NPO except, and except is usually X with a line over it. If you see an X with a line over it, it means except. So NPO except water. That means the patient can have nothing by mouth except water. Or NPO except ice chips. So NPO can be modified a little bit. Good. Do you remember we talked early in today's lesson, way in the beginning, that if we don't know what something means, we need to ask? Here's your story. This is a true story. We owned the scrub shop for almost 20 years. And I would work at the scrub shop at the front register, and I would help people find stuff. And we were the only scrub shop in the county. But we also would, customers would come to us from other counties because we offered a significant discount. And they all knew that I taught the CNA program. I've been doing this for a long time. So we had a nurse that came to us from Tampa. She actually worked at one of the big teaching hospitals in Tampa. And she came in and she looked at me and she said, "You still teach CNA class?" I said, "Yes." She says, "I got a story for you." This is probably about 10, 12 years ago. I still tell this story to every class. We're going to call her Kathy, the nurse. She worked in the cardiac cath lab. And it was about 4:45 in the morning. She goes upstairs to get the first patient for the day. Doc is down in the cath lab, scrubbing in, getting ready for surgery. She goes up to get the patient. When she walks in the room, the patient is sitting in bed, eating. So she goes and finds a nurse. Well, actually, she asked the patient first, "Why are you eating?" Patient says, "The nurse brought this in, said I had to eat it before my procedure." She says, "You're NPO." He says, "I know, but she said I had to eat it." So Kathy goes out and finds a nurse taking care, assigned to that patient. She says, "Why is the patient eating? He's NPO." Nurse says, "I don't know. That patient has a student nurse. Let's go ask the student nurse." So this is the conversation as it was relayed to me. Kathy asks the student nurse, "Why is the patient eating?" Student nurse says, "The patient's NPO." Kathy says, "I know the patient's NPO. Why is the patient eating?" The student nurse says, "Because he's NPO. I went and got the tray myself." Kathy says, "What do you think NPO means?" Student nurse says, "Nanas, pineapples, and oranges." True story. So now we got a doctor, a surgeon, down in the cath lab, ready to do a procedure, and the patient cannot have that procedure done. So now we've got a physician with time to kill. Do you think that makes him happy? We got a patient who needs a procedure that cannot be done now. And that puts them at risk for a major heart attack until we can get them down to the cath lab. Right, but they've got other people on the schedule, so this person has to be bumped to the end of the day. So this affected a lot of people, all because the student nurse did not know what NPO meant and guessed. Now, this makes me absolutely crazy because Uncle Google is hitching a ride in your pocket. And it wouldn't have taken 2 seconds to ask Uncle Google, what does NPO mean? But who should this student nurse have asked? The nurse, that's right. Instead, she made, and nanas isn't even a word. But it affected a lot of people. So we don't make things up. We don't guess at what something means. If we don't know, we ask. It's that simple. If we don't know, we ask. And if it makes us look a bit foolish, so be it. You're going to look a whole lot less foolish asking, "What does this mean?" than you will look trying to justify nanas, pineapples, and oranges. True story. All right, so these are the forms that we used for the test for intake and output. In a clinical setting, your forms may look a little bit different because everybody has a different way of documenting. But the form on the left on this page, you will document intake. The form on the right is intake and output, but these are numbers. So if we're documenting on a quarter scale, it's just a checkbox. If you're documenting actual numbers, we do that a little bit differently. But I want you to pay attention to this form real quick. We're going to see this again on Monday, intake and output form. Please make sure that you're documenting the right thing in the right place because both of them are in the same form. If it's intake, it has to go in the intake section. If it's output, we have to document an output section. If you document for the test that you took 450 cc's of urine out of the drainage bag, if you document that under intake, you are saying under oath, this patient drank 450 cc's of urine. That's right. We've got to make sure we get it in the right place. Good? Good. Okay. All right. So this whole lesson talks to you a little bit more about intake and output. Let's go ahead and show you that video. I don't have anything to feed you guys, so let's show you that video on eating. I got the...
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Okay. Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Want to take the napkin? There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate and the amount of fluid they drank. Using my documentation form, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
On a 3, 2, 1.
All right. Any questions on feeding?
Should we throw the spoon away?
Yep. I know it looks metal. That's one of those fancy plastic ones that look metal. No, for the test, it'll be a plastic spoon of some sort. Nakalunga says, thank you for your lovely and informative videos. I passed my Florida CNA exam on Friday. I was a little nervous, but I just did my skills exactly as you demonstrated. Congratulations. Great job. Okay, so I want to bring up something that Helen put in the chat just a few minutes ago. She asked can you throw that one up? Okay, no, not that one, the next one. There we go. Medical abbreviation for CID is what? Because Uncle Google said it's 3 times a day and I'm not sure. So this brings up a very good point that I need to say, because I just said, Uncle Google is in your pocket. However, Uncle Google may be wrong. Keep that in mind. This is actually TID, not CID. But there is no CID in medical abbreviation that I'm aware of. But understand that Uncle Google may be, just trying to make something up to give you an answer. Be careful. Ask somebody ask the nurse. Whoever put the medical abbreviation in is really who you need to ask. All right, last skill for today. Page 152. Peri-care. This is a long skill. This is the second longest skill that we have. 17 minutes. Every principle is used except for shoe rules. This is just like partial bed bath. A lot of the same steps are going to be in this that we had in partial bed bath. We have a video. All of the principles are spelled out. This is a mannequin skill. Abbreviated steps up here. But let me talk to you just a little bit about peri-care and incontinence in general. If you look on page 153, we have a care plan at the top of the page. It says the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the bedding and the gown is dry. That's a miracle. It never happens like that. But we're going to take the gift they give us for the test.
But after you don't take it, you have to change the bedding.
In a clinical setting, we're going to change anything that's wet. Anything that's wet. We don't want the patient laying in a wet bed or wearing wet clothes. Whatever's wet. But for the test, this is a simulation skill. There's going to be a pad under them. It's really dry. There's not really urine. We're pretending here. Okay. All of the supplies are listed at the bottom there for us. This is a 5th grade review of your urinary system. You have 2 kidneys. Those kidneys filter blood 24 hours a day, 7 days a week, never, ever, ever stop. As they filter the blood, they remove impurities and they create urine. And that urine drip, 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 drips down into your bladder. Your bladder is nothing more than a Ziploc bag. It just holds the urine. There is a valve at the bottom of the bladder that holds the urine in the bladder. When you go to the bathroom, the valve opens, the urine comes out. When you're done going to the bathroom, the valve closes, and now you're good for another couple hours. Normal urinary system. What happens when our patient is incontinent is everything else still works. Kidneys still filter blood 24 hours a day, create urine, drip, 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 down the ureters, into the bladder. That does not change. What has changed is the valve. The valve is no longer working. So those drips, as they come out of the kidneys, down the ureters and into the bladder, there's nothing to keep them in the bladder. So they come out of the body. Your incontinent patient is going to be wet all the time. If you have a patient who is dry, 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 really, really wet, you do not have an incontinent patient. Because that means that valve has kept that urine in the bladder. That is not an incontinent patient. That means you need to be getting them up to the bathroom. Good? Make sense? So in incontinence, this whole system still works. It's the valve. But the valve is a muscle. If I sit on the couch 24 hours a day, 7 days a week, I'm going to get really flabby. But I could start to exercise and gain some muscle strength back, right? We could exercise this valve and help it regain its previous function. This is called a bowel and bladder retraining program, and it means we get the patient up to the bathroom every 2 hours around the clock. At 2 a.m., we're waking them up and taking them to the bathroom. And by sitting them on the toilet, that valve will automatically relax. And then it will try to close. Now, it's not going to close right away because it's really flabby. But over time, with this repeated every 2 hours around the clock, within usually 3 to 5 days, you can get some level of continence back in your patient. But it's got to be consistent. Everybody has to participate every 2 hours around the clock. Good? So let's talk to you about why incontinence is a problem. Adult urine is not like baby urine. The acidity of your urine is going to be based on the foods that you eat. Babies eat very mild foods. Rice cereal, baby food, formula, breast milk, very mild. That means their urine is very mild, very neutral. You can put a pamper on a baby, put them to bed, wake up 8 hours later, they still have skin on their tush. Adult urine, not like that. Adult urine is very acidic because what we eat and drink is very acidic. So when you put an adult patient in an adult brief, we don't call them diapers, in an adult brief and leave them all night, that acid is going to eat the skin. So when we have an incontinent patient, we can't treat them like a baby and just put an adult brief on them and let them go. We need to make sure that we're changing and cleaning that patient every 2 hours around the clock. We've got to get that acid urine off of their skin. These adult briefs have some limitations, though. When the patient's out of bed, an adult brief is indicated. Nobody wants to wet themselves in public, right? So an adult brief is indicated. The problem with adult briefs is they're plastic lined. That's going to hold in body heat, block out light, and we already have moisture there, the urine. So now we've got warm, dark, moist. What grows there? Yeah, all the pathogens. So when we have a patient in an adult brief, we're setting them up for frequent infections. When the patient is in bed, there's a better way. Out of bed, adult brief, yes. But in bed, there's a better way. When the patient is in bed, if they're laying on a pad open to air, no brief on, that urine, as it comes out of the body, remember, it's always going to be dripping, right? Incontinent patients always wet. That urine gets spread out on the pad, not held right up against the skin. Light and air are circulating, so we have less infection risk when the patient is laying on a pad open to air. But there's a problem here. This is good for the skin, better for infections, but that pad, let's talk about that. Remember that our body temperature is about 98.6 degrees. Urine is made up in the furnace area of your body, so it's a little bit warmer. Urine, when it comes out, is about 101 degrees, roughly. 101 is hot, right? Now, we also learned that room temperature always wins. So that 101 degree urine is going to exit the body, spread out along that pad, and it's going to cool to room temperature. So what do you think that pad's going to feel like? Cold, wet, slimy, icky. We want that pad changed as quickly as possible. So the first thing we're going to do in this skill is change that pad. But now we got a wet butt on a clean pad. So once we get the patient all cleaned up, front and back, we're going to change the pad again. So we got a clean butt on a clean pad at the end of the skill. And we'll have that for 2 hours, and then we're going to go in and do it all over again. 2 hours after that, all over again. 2 hours after that, all over again. So remember, that pad is not going to be comfortable for the patient. Change it out first. then change it again at the end. Okay? Washing rules apply. We don't put soap in the basin. We use paper towel to turn the water on. We check the water. They check the water. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get your surface wet. All of those rules still apply. So I'm just going to skip past all those. Okay. We don't use lotion for this skill. So we're going to follow the care plan here. Every skill starts with an opening. We're going to place our barrier on our table, then our clean supplies on the barrier. We're going to fill the basin, have them check it. We'll put a privacy blanket on and then some gloves. Remember, the first thing your gloves should touch is the patient. We're going to change that chucks out. We already know how to do that because clean rolls toward me, dirty rolls away. So we already know how to do that. And then we're going to expose the patient, but we only want to expose the area that we're cleaning. So I don't want to just come up here, pull the sheet down and pull her gown up. This is uncomfortable for everybody involved. So we want to put the privacy blanket on, roll the privacy blanket up, and put a towel over her legs. So the only area that's exposed is just the area that we're washing. Privacy blanket over the sheet, pull the sheet down. So we have the blanket on. We're going to roll the blanket up to her waist and put a towel over her legs while we're cleaning. You'll see that in just a minute. It's going to look like this. That way we're exposing just the area that we're trying to clean. We'll wring those washcloths out thoroughly. Remember, no drippy wet washcloths, and we're going to use that leaves method. You guys remember the leaves method that we learned? So I'm going to take my washcloth, put it in my dominant hand with the free leaves at the top, and tuck in the two side corners. I'm going to use my other hand to kind of hold her open a little bit. Let me switch hands here because I'm on the wrong side. I'm going to kind of hold her open a little bit and go down the inside middle. I'll fold that over. I'm going to clean outside, top to bottom. We only go in one direction, never back up. Fold that over. Top to bottom, never back up. Fold that over. And then this right here where the leg and the groin meet, that skin fold, top to bottom, fold it over, top to bottom. Whatever I wash, the exact same way. So nothing here to learn. You can go. I know you're running on time. So we always move top to bottom, never back up, because we don't want to bring pathogens to the urethra where they can get into the bladder and cause an infection. We're going to rinse the exact same way, and then we're going to dry top to bottom. Once we do that, we're going to cover her back up with that privacy blanket, turn her on her side, scoot toward me, roll away, and then we're going to clean the back side. Remember, that butt has laid on that wet pad. We've got to get that acid off of the skin. So I'm going to take my washcloth, hold it in my hand with the leaves method, leaves facing up. I'm going to start at the anal opening and go up that center crease. Fold that over. Clean one cheek, fold that over, clean the other cheek, fold that over, and once more up that center crease because it acts like a riverbed. All the urine goes up there. Whatever we wash, we rinse the exact same way. Nothing new to learn here. And whatever we rinse, we dry, bottom to top. And then we're going to change that chucks out one more time. Good? We're going to leave our patient in the middle of the bed covered with the privacy blanket while we take care of all of our supplies. I can't touch those washcloths and towels without gloves. Think about where they've been. I need my gloves on for that. So I'm going to take care of all of my supplies. I'll clean my basin, put it away. And then once I've gotten everything cleaned up, then I can take my gloves off, remove the privacy blanket, covering the patient with the sheet, and then I can do my closing.
On page 153, it says bath blanket. Are we using that
So a privacy blanket and a bath blanket are actually the same thing. And in your book, let me, Right. So everything in healthcare has two names. I don't know why. I didn't make the rules. But if you go to page 37, I've got all of the supplies there on page 37 of your skills book. I've got all of the supplies there with their alternate names as well. Yeah. Yeah, it's shaped like a kidney. Kidneys are kind of shaped like beans. I mean, have a kidney bean. That's how it actually got its name. It's shaped kind of like a kidney. All right, any questions on this? Let me show you this video. You're welcome. You're welcome. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri-care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm, not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you, and roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient, tuck it under her hip, unroll the clean one, and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you, and scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink, rinse the basin, pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done. Okay. So this weekend, you have 2 chapters of homework, chapters 8 and 9. 8 is on nutrition. You are responsible for understanding how diets impact health and that certain diets are prescribed for certain health conditions. Chapter 9 is on rehabilitation. It's going to go over all of those positions we talked about earlier today. We only have 2 classes left. 1 skills day. So you're down to the final 3 skills. And what we're going to learn on Monday is catheter care, which is a variation of Peri-care. We're going to learn how to empty the drainage bag and how to help somebody with a bedpan. So Monday is all about toileting. Not a whole lot to teach you. So you will have about an hour, hour and a half of practice in class on Monday. I know I wanted to give you at least 30 minutes. I kind of ran a little long. I'm sorry. And then next Wednesday is graduation. We're going to talk about renewal. We're going to talk about continuing education requirements, how to find a job in healthcare because it is different than other industries. We're going to talk about some interview techniques, and I'm going to help you craft your very own reply to tell me a little bit about yourself. There's actually a formula you can use to craft a response to that will get attention. Okay, so I'll help you guys with that on graduation day as well. So still have a little bit to go, but the hard part, guys, is over. Only 2 classes left. You guys have done fantastic. I'm so proud of all of you. So proud. Does anybody have any last questions for me today? Oh, no, that's not. This is the review sheet I handed out to all of you. If you need any, if you're missing any review sheets and need any, they're by the door. Those of you who are attending virtually, please remember these review sheets are on flcnatraining.com. And that will allow you to download that very same review sheet that the students are getting in class. So thank you guys for joining us. If you did not see the game show, go back and watch the replay. There's 15 practice questions that would be very similar to what you might find on the state exam that will help prepare you for the written test. Have a great weekend. I hope you guys do something fun. Again, if you're a school and you're going to the state leadership conference, come see me on Friday. Other than that, I will see you guys on Monday for our class 7. Until next time, happy caregiving. Bye. Any questions?